Good morning to you all. I think it's been really pleasure and privilege to be here at this NCHP 2021. And I would like to begin and thank all organizers, especially Sahiba and his whole team who has done a great job of organizing this hybrid conference. Also my close friend and Dr. Tejinder Singh and all my colleagues from the NCHP and AHP. And all delegates. Thank you so much for this particular conference. And this is going to be now new normal, where there'll be few people listening to you and few people will be online. And that is going to be our next few years normal. Now, I'm going to really talk to you on making of CBME background perspectives. I think the whole theme of this conference is so interesting, looking back and looking forward and leaping forward. I think it's very important to really understand how we look at the history so that we learn for the future. And this has been always the thing of learning point. And therefore, I think this topic is extremely relevant to see what was the background and what we have resulted into. I have no financial conflicts to declare. Thanks to the SGRD University, and special thanks to my close friend, Dr. Krishna Sheshadri, who has been part of our journey. Now, I would like to begin with the Alex Felix, who is an athlete and who has won 30 international medals. And she said very nicely, everyone sees the glory moments, but they don't see what happens behind the scenes. We see all medals, we saw Neeraj Chopra, we getting medals, but what happens behind? They are years of kind of an experience they have. So it all began somewhere in November 2004. I remember there was a conference in Vellore. In 2004, I remember there was a conference where me, Tejinder, and everybody was there. And we were trying to plan a South Asian Institute. And it did not happen some way. Something happened and it did not really happen. So from Vellore to Mumbai, I was traveling with Dr. Burdick and Dr. Chandrakant Patankar. And we had a discussion that we must do something for this country. We must do something for changing of this curriculum. And on-flight discussions resulted into two things. One, the birth of GSMC Femur Regional Institute. And that was one landmark movement, I think, that resulted. Secondly, it also resulted in one article in Academic Medicine. And this was the article which came as challenges and issues of medical education in India. And this article was in Academic Medicine, which is the highest journal in medical education. And there we wrote that our curriculum needs to change. And of course, I was very happy that one article has been published. Suddenly, in 2007, I got a call from MCI president. And they called me, you have to come and present yourself. So I was little anxious, scared. Why is MCI president calling me? So I went there, and along me with was Dr. Rita Sood. And I'm sure we have really feeling her that she's not here. And they asked me, why did you really write this article? And remember, everybody sitting there, president, then all vice presidents, whole MCI committee. And they're asking me that you have written an article on academic medicine about challenges and issues in medical education in India and why you have written that. Then we told them, thank you, Rita, that time for full support. I think we told them what was wrong and what needed to be fixed. And we just told them that we need a change. We need a paradigm change in our curriculum. Now they were, I'm sure, probably impressed, and they organized one Nagpur conference. And they called it as the MCI Platinum Jubilee Conference, 2008. I'm sure there was many speakers, 4 or 5 speakers. I think one session was Tejinder had taken and I had taken one session. And we talked about how ME units and faculty development programs should be really developed. And it was a wonderful conference like this. But that was the idea of developing faculty development programs. At the first time, any administrative or government body has taken a faculty development program in the world. And they have spent so much of money. I think the whole idea came out from this Nagpur conference. And that resulted into the Platinum Jubilee 2008. And it resulted into more than 350 CMEs. And that got the boost of the medical education in India. And in fact, that was the time Dr. V.P. Mishra and his whole team resulted into the National Faculty Development Program. That is, nodal and regional centers, 5+5 were really developed. Now it has increased to 10 and 12, that is 22 centers. But that was the first time when the faculty development program started. You know, government investing into faculty development program. It was a very major step at that time. And that pool has really helped us to make some changes. Now then came July 2010. And all of you really know that somewhere in April 2010, MCI was dissolved for the first time. That time it was suspended. And that time the board of governors were brought under the leadership of Dr. Sareen. Now this was the first board of governors and appointed in 2010, and they appointed two groups, UG group and PG group. And we had practically spent weekends into MCI. I remember every Saturday morning we used to go there from July to February, and we used to spend there till Sunday evening. And we used to have a lot of discussions about how to go about this. We took data from everywhere, World Bank, WHO, then Indian Medical Council, registers, faculty, graduate perceptions, and almost 97 curriculum. And this all was really churned to formulate something which was very classically called as a Vision 2015 document. And all of us, you know, that many of the elements really came into the curriculum from Vision 2015 document. And this was the one which conceptualized many elements. And it brought the new CBME curriculum. And the whole aim was to be globally compatible with local relevance and to bring the quality of healthcare into that. You know, it's a wonderful kind of a document which was created. Now, the first thing in the Vision 2015 was an ideal recommendation. It was what was expected to be. But the most important challenge was, you know, our scenario. We know our 400, 500 medical colleges of different capacity. How do you convert that into acceptable and actual curriculum? You know, it's good to have what is ideal. How do you convert it into on the spot? You have thousands of students. You have so many stakeholders. Everybody is trying to pull and push. How do you really bring about a change in that particular field? So I'm going to take you to these 10 C's of CBME curriculum. That is concept, content, committees, consultants, concurrence from the authorities, CISP, cooperation from the universities and colleges, criticism, challenges, and continuous development. You know, these are the 10 C's. So that you can call commandments, you can call 10 lessons, you can call 10 C's, but this is what I'm going to speak in my next few minutes. Now, what began was a brainstorming session. From 2012 to 2014, every 1 month or 2 months, we used to spend our 1 or 2 days into MCI, and there were 4 people. I remember only 4 people. That time, you know, Krishna, I'm sure Dr. Krishna Sheshadri is here, Dr. Kaul, me, and the great, our leader, Dr. Raj Lakshmi. And I think we spent days together to see how we can conceptualize the whole Vision 2015 into GAMR. And that was the time we got birth of graduate medical regulations of 2015. Now, the Vision 2015 laid the path. 97 document was discussed and revised. And we brought the new elements into all that. But there was a lot of reaction from various departments. Every department wanted its own pie. You know, one department said that we cannot be in second MBBS. We want to be in third MBBS. Some people wanted, we want 2 months extra. We want this, we want that. You know, it's like a typical parliament which really started there. And everybody, there were morchas on MCI. There were a lot of fightings which went on. How are you going to cut down our time and all? But over a period of time, people accepted this change. And the new elements got conceptualized into the whole system. We got a lot of help from the legal team. And finally, through expert committee and DOG, we could really bring some amount of this GMR development document. So what were the paradigm shifts in this new curriculum? I think this is what we must first understand. What had changed in this curriculum? The first thing is we tried to convert from syllabus to curriculum. That was a major change first. Secondly, we went from goals to competencies. We tried to look at what a student would like to achieve rather than what were our goals. We also changed from what to how and why, and sometimes why not. We changed it towards basically. We also went from knowledge to behaviors. This was a major change. All of us, our curriculums were knowledge-based. We wanted to change to skill and behavior. And that was a change which we tried to bring. We tried to bring attitudes. We tried to bring professionalism. We tried to bring skills in a big way. Because ultimately, unless you bring that, you are not going to really have a change which is going to happen. And of course, from idea, which was most ideal, to achievable. That was one of the major challenges all of us have had. So these were the main paradigm shifts from 97 curriculum to 2019 curriculum, what we can really call. And we developed this model. This whole model, I'm sure there were 5. This was an Indian model. We have CanMeds, we had SCGME. So we had this Indian model of 5 things: clinician, leader, communicator, lifelong learner, and professional. Very aptly put by the UG group. And I think once they developed this whole concept, we tried to build upon the conceptual framework because we wanted to put this into a subject-based competencies. Having done that, this was a model which was created where we tried to merge the subject-based competencies with role-based competencies. Like you want to have the leadership, clinician, lifelong learner, bring it into, and then trying to make it that way. So the next question came about, how do you develop the content and the framework? Now, this is where all UG departments and working groups and committees came. There were 22 subjects in MBBS. I don't know how many of you really remember that. And there were 65 teachers across India. And they were all senior teachers. They were all reputed teachers. The process, they had multiple meetings in the MCI. 3 or 4 people from each subject came together and they started developing this content. And it took 1 to 2 years before they developed the framework and structure. The challenge was to align with them to the new concept and develop frameworks. And this was again a difficult challenge. Academic cell with the subject experts held multiple meetings there. We were not partly involved into this. We only probably guided them, but that was a time when this all work happened. So the content again came from many sources: WHO data, Ministry of Health data, ICMR data, graduate and faculty perceptions, World Bank, and we tried to get all that data to merge what was relevant to our country was really put down here. So if you look at our competency document, it is a work of subject experts. It is a broad framework. Sometimes you say it's too broad. It goes to the objectancies rather than EPAs. It's a little other side of the conundrum. But that's what the experts really thought. And each subject level, there were sub-competencies and predefined outcomes. And I think that was the whole concept which was really put. And the book came out with sub-competencies for each subjects, vertical and horizontal integration. Miller's pyramid was used. And one of the best part is they came with the procedures for certification, that is 48, mainly in the internship. And when the internship will come, every undergraduate will have to certify himself that he has been able to. And this is where the skill labs are going to be of a great importance in future. So if you really look at the concept of CBME, let's understand what is CBME. Doing the right thing, what doctor is able to do. That means he should have technical competencies. He should know about clinical skills, practical procedures, investigations, patient management, health promotion. Remember, these topics are not taught to us. Now they will have to be taught post-COVID area. Communication, information handling. These are all things which a doctor should be able to do rightly. Secondly, doing the thing right. That means how the doctor approaches the clinical practice. And he is to have a scientific understanding, because the knowledge is changing so fast. Today, we are dealing with an era of pseudoscience and lot of news which come. And our science is weak. You know, today, if you look at the COVID times, there were so many fake news which really came. And we had to all deal with all that. Attitudes and ethics, that becomes a very important part today for a doctor. Decision making, this is one which is not so well talked in our country. We need to focus on that. How do we make our students to make decisions very quickly, not only go on investing a patient? And of course, team working. Today is a day of multidisciplinary team workings, whether it's a cancer, whether it's ulcerative colitis, whether it's a Crohn's disease or a diabetes. Today, we require a team of people who are managing. It's not a single doctor who is going to manage. So in that case, we must really understand how we are going to do team working. The third thing is the right person doing it. That means personal development of a doctor. Doctor should be developed as a holistically developed rather than developing only as one person. So if you look at, this is what a competency or outcome-based teaching is. So what we really need to do is learning outcomes are identified, they are made explicit and communicated well to everyone. Everybody should know what you are supposed to learn, how to teach, and what I'm supposed to know at the end of particular term. There should be a lot of clarity on the thought. Decisions about the education program and what is taught are based on agreed learning outcomes. So everybody should know what are agreed learning outcomes. And there is a move from a time-based to the competency-based. I'm sure this is going to take time. In our country, we are immersed with time-based. We want at 4.5 years, everybody to pass. Some of them may not be competent. If you try to extend it to 6 years, probably there'll be chaos. So we are not ready for this time-based to competency, but ideally over a period of time, it should be the way it should be. Having said that, what is the concept of CBME in India and how it was contextualized so that it was implemented in India? And this is one of the most important aspects, you know. CBME, which has been put all over the world, people have developed only 13 EPAs and allow colleges to do. The US has done that way for undergraduates. There are many people just say that you have to achieve this. But in our country, it doesn't work. Our country for last 60 years or 70 years is used to top-down approach. We look for every MCI word. We look for every NMC word. So we have to give those guidelines. If it have given open to everyone, there would have been chaos. So we need to contextualize this. We need to give it in that particular format where people are used to. So ideally, competencies are for a whole course. Here, outcome-based framework is being fit into subject-based curriculum. So we are doing something which is in local alignment. And so pre and paraclinical, these are sub-competencies, abilities or milestones which end year of competencies, which will build over to bring the final 48 competencies when patients are being treated at the final. So that was a kind of a slight amount of Miller's pyramid. We tried to look at it from facts gathering to interpretation, demonstration of learning and performance integrated. I have spoken on this a number of times, so I'm not going to speak on that today. But you should realize that this was a building up of that pyramid to achieve the final competencies. So these were the key features of the new curriculum. The most important feature of the curriculum is a shared responsibility. That means the components like self-directed learning, components like elective, where student also has to take a lot of responsibility. All of us as a teacher should realize that so many years we were taking responsibility of the education. Now is the new era where the students also has to share the responsibility of learning. Students cannot say that they are not responsible. They have to be equally responsible. Whether it's a postgraduate or undergraduate, he has to be equally responsible. Secondly, self-directed learning is part of the game because the knowledge has expanded so much. A teacher cannot teach it within that particular framework. And there's a lifelong learning. So student has to learn on his own and develop his own skills. Patient and learner centered. The whole concept is now not knowledge centered, but it's a patient and learner centered. What does patient need? What does the learner need? And multiple assessments. I'm sure this whole conference, I was so happy. I'm sure it is all Tejinder's brain, but he has really put a lot of effort into assessment being because that's the real question today. How do we make the programmatic assessment and the assessments more involved into the universities? And that if we are able to achieve through this conference, I think we will be able to really get things. So that is the whole key features of this curriculum. So they formed committees, and I'm sure committees sometimes work, sometimes do not work. And this was a committee, expert group committee, and I was a part of the committee for almost 11 years. And I mean, if you really see this India, unity in diversity, that means we had people across India. We had on the top was Tejinder and Dinesh. Madam Raj Lakshmi was at the central point. We had Subir Malik from the AIMS. We had Dr. Kaul from the MMC. Praveen from Gujarat. I was from Mumbai. And we had Vijay Raghavan brought his own challenge from the own wisdom from the SRMC. Krishna from Chennai. I'll talk about him more. And if you see Sajid from Kottayam. So we had people across India. Now, if you really look at the expert group, each one was different with used good qualities of each. I think Krishna was innovator. Krishna really got ideas, wonderful ideas he gave. And we tried to develop those ideas. Tejinder, as you know, is an ocean of wisdom. And all of you really know, he's a just wisdom. You know, his every word, his every insight is valuable to all of us. Sajid and Praveen were taskmasters. Vijay Raghavan got his experience, administrative experience, as well as integration experience. Chalam and Subir were people who gave us an external view and really a good kind of a feedback. And of course, there were many people walked with us. I mean, Kaul Madam, Alka, Dinesh, Trupti, Sunita, Sanjeev, and I'm sure many more. In fact, if you really see for every booklet, we have taken help of many people. And that's where I feel this committee really went on and we tried to develop more and more. So what happened? There were healthy discussions. What we really brought, my really role was not only to monitor, but to have a nice environment into the whole committee. There were arguments, of course, when there's so many people are fighting, we used to have fights. I'm sure MCI temperature must have gone very high during our fights. For about concepts, presentation and implementation was always common. We must have spent a lot of time fighting, but finally decisions were consensual. What is most important is that unless everybody is agreed, we never push forward. Many took weeks, but once done, it was contributed fully. And everybody had his own task. Somebody would create a concept, somebody would create language, somebody would really look at the format, somebody would look at the feedback. And it was all done very well. Few discussions ended in dinner table like Pind Baluchi or all these places, which we had one of the best times into that MCI room. I don't know what we call that MCI, how many of you have stayed into that MCI hostel. But I think it was one of the, we must have spent hundreds of days on that particular MCI book, but it was something which was worth it because the kind of output it gave was worth it. Second point was getting concurrence from the authorities. In India, it is very easy to create a document, but to get it passed through so many committees and parliament and ministry is one of its biggest challenge. So curriculum was ready in 2015. We submitted to the Ministry of and DGHS. And it was kept into typically the red kind of a file. Nobody looks at it or it's up and down, change this. Multiple sessions with DGHS committee and ministry, pressure from various associations and others. You know, in a typical government kind of a thing, it went on for 2 years without any action on this. We used to call every 3 months, they used to call us, okay, do this, tell us this, minor change. Changes in BOG, there were so many times that time the changes happened in BOG, MCI and BOG. I think the two people really helped us that time was Dr. VP Mishra and Dr. Raj Lakshmi. And finally, framework was released in 2018. And I think there was a call from the PM's office which said you release this. And they were forced to release that. I don't know how it went. I don't have any contacts in PM office, but it happened. I think all of us should realize that there was a need and it happened. And GMR in 2019 was published. And then the procedure really started in further. So what did we really do? Ideal to achievable. This was the one question we really put forward. Had to present this to few who understood little of curriculum development. You know, this always happens. I'm sure all of you have gone through. Sometimes you have to present to somebody who doesn't understand anything about it. But you have to really be patient. You have to be really careful and present to people so that they understand and they do it. Sometimes had to listen to suggestions which did not agree and fully and satisfy their ego. This happens, I'm sure sometimes, but for the larger good, we had to take some suggestions. So what was the approach? Krishna said it very rightly. Choosing good to ideal to make it achievable. This is something which is important in life. We have to choose sometimes good to ideal, because ideal is not possible, because otherwise it would never be achievable. This is one approach we took. Sometimes we could have taken an approach that we want an ideal. But remember, in a country like ours, we cannot have an ideal, but sometimes you have to be achievable. So if you want to make a step in life, it was a road which was very clearly told to me by my teacher, that if you're going on a road and you see a stone in front of you, what do? One way is to try to remove that stone, which is very difficult at times. So just go by the side of that. We have to go ahead. So we just tried that philosophy. I have to consider all parts of India sometimes. Sometimes people used to say, no, in Northeast Asia, if you put this sentence, people will not be able to do it. So we have to put those sentences and we had to make a change. And we did that. And so we made global but locally relevant kind of a curriculum. Two people I would like to really thank. One is Dr. V.K. Paul, who is from Niti Aayog. He really helped us. He was the chairman of the DOG, and Dr. V.P. Mishra. And of course, all the office bearers, presidents of MCI, presidents of BOG, presidents of NMC, and Ministry of Health and Family Welfare. All of them helped us to really build this curriculum and bring it to the state what we are. So the next step was developing the new elements into the curriculum. And this was again a task. So we had various new elements like foundation course for 1 month, early clinical exposure, electives, emphasis on skills, ethics and communication attitudes, and 1 additional month for first year. Now, all of us know that professionalism came into all over the world much earlier. The first ABMI booklet on professionalism module came in 2005. Before that also, they had many booklets. It is the Internal Medicine Board, American Board of Internal Medicine. I was part of the ICMR Ethics Committee cases development from 2003 to 6, where we developed ethics committee cases for medical students. So there was a need for a module on attitude and communication. We all felt that this is not there. And there were CARV initiatives by Dr. Krishna, responsiveness and values. So Krishna gave an idea introducing case-based module. So we all liked it. We said we must really pick up that. So we used these domain docs. That means though we have a knowledge, skills, attitudes, values, responsiveness, and communication, each of these has different aspects of this. So they are all merged together. They are not different. Only components and their importances differ. So we tried to use this model to develop our attitude. So ATCOM came in 2018. And since then, it is actually started in 2015, emphasis on communication skills, connecting with the patient needs, formalizing the informal curriculum. That means what was taught by teachers informally, we tried to formalize it. And awareness of ethical issues and improving attitudes of physicians. So ATCOM came. ATCOM was a great success, well received by faculty and staff, more than many publications today on ATCOM. There are a lot of books on ATCOM. I know at least 4 or 5 books on ATCOM. Each competency has been checked and they have given how to really do that. A lot of more books will also come. And I'm sure, but then came the challenges of implementation of the whole curriculum. Variability in ability of various NCs, RCs, MEU and trainers. Our country is big, so there's a vast difference. Faculty development is a big issue. Though we have done very well compared to many other countries. Now look at many other departments are trying to look at how India has done it and how the medical people have done it. Multiple level change, multiple stakeholders, synchronization with guidelines from DME and universities, develop materials in context to reforms, motivation of MAU and directors, and of course, making change happen. Sometimes you have only papers, but it doesn't happen at a ground level. And changes in the minds of faculty. Standard concerns and issues came. Work overload. This is too much of work for us. Unwilling to learn new skills. difficulty in creating meaningful assessment tools. Now, that is what today, this conference, we are trying to emphasize. And many other issues started coming into this. So when CISP came, it was a typically framework got published and GMR was not gazetted. So everybody start looking at it from his own perspective. You know, there's a story of an elephant and 4 blind people. Somebody saying this is like this, somebody saying this is like that, you know, and everybody was fairly confused what it is really mean, how to really go about this. So we all sat and realized, no, we need to make it more clear. We need to now trying to bring booklets, which are guiding forces for people to really change. And that was the whole idea of developing booklets. So what was MCI's approach for implementation at that time, BOGs? That basic 3 elements. One, the strong faculty development program which our country has. We will take it forward. Use all NCs and RCs. Curriculum Implementation Support Program. That is CISP, which all of you must have gone through. And MCI, BOG, and NMC booklets. These were kind of guiding paths. So the MCI network today, you know, there are about 10 nodal centers and 12 regional centers, which across India have been able to now train more than 55,000 teachers, at least in basic course, 3,000 to 4,000 teachers into advanced course. Now that's a huge development. Now these are the people who have been helped us to really develop this curriculum in future. CIP concept was really formulated in 2012 by Dr. Anand Zakaria. You know, he was the first famous fellow from India, very intelligent, and he's a person who really helped us to really take it further. And Dr. Rashmi Vyas. And then I think that time we conceptualized this CISP, but CISP took time to develop from 2015. And then we utilize existing MCI FD network. And now we have more than so many teachers of CISP. Now, what is the problem with our whole taking it? You know, it's a story of, we used to say, no, when you sit in circle and we start selling one person's story to another person, by the time it comes to the last person, it is completely distorted story. Now, that should not happen to our curriculum. So what we really said, okay, let's try to standardize the whole thing. I'm sure it is still happening to some extent, but let's at least minimize it. So step 1 was expert group would first discuss. Then it would give it to NCRC conveners through workshops. NCRC would go back to their colleges and give it to their MU faculty. Then you give it to the various colleges and their representatives. And lastly, it would go to all faculty and students. So it was a 5-stage program where the knowledge and the concepts need to go into the further thing. And this was one of the most difficult jobs because you are allowing in 548 medical colleges, more than say 85,000 teachers, and look at the kind of vastness our country has. And we are trying to put, so need to standardize few things. So CISP came in a basic workshops. Then we tried to do 1 and 2 workshops, booklets, conferences and workshops, and journal articles and courses. So CISP 2 was successfully conducted during lockdown. I think this was a time of challenge where everybody really stood very well. And I think all my colleagues really took quite a hard, whether it was expert group, whether NCs, RCs, college MAUs. I really appreciate there's so much of hard work. And there were more than say 500 colleges conducted CISP2 and more than 15,000 teachers got involved in that. So imagine how much of kind of a motivation and enthusiasm we went through. Sometimes it could be because of MCI trying to push also, but I think it worked. So successfully conducted over 500 colleges and more than 30,000 faculty trained in both CISP1 and CISP2. So, sorry, I'm sure. Am I going back? Yeah.
Yes.
Fine. So then the concept came of developing various booklets. I don't know how many of you have really seen those booklets, but now there are almost about 10 booklets and 5, something like that. And I think one more will likely to be coming. So we tried to bring out various booklets like this, which are, I personally feel each booklet has its own value. We took a lot of help of people around us. We called many experts from the country who gave us the idea. Then we developed it. So the credit goes to many people developing this book. Foundation course has been designed. Foundation course was first tried, but people tried their own ways. But over a period of time, people will now align it with their local needs, and it will refine over years. Early clinical exposure was a very challenging thing. Making examples was challenging for the first MBBS. So we took first MBBS teachers. We took teachers from biochemistry, physiology, anatomy, and they helped us to create cases. We looked at their clinical concepts and we tried to make that more useful to the students. Alignment and integration. I think one of the best part which Vijay Raghavan and Krishna were involved into integration museum. So what we did, we took away the last four, we took away the first four, and we took middle four steps of Ronald Harden. I thought they were the best to implement in our country as an integration. And that was a concept which worked very well. It was not too very much difficult. At the same time, it was not too complicated, but it was worth giving the whole concept of integration to the country. And I think that worked very well. Skills training, I'm sure there is going to be a session after this. Dr. Fazana and his team is going to speak about it. But I think emphasis on skill training is one of the most important aspects of this curriculum. We tried to push skill labs. Initially we tried with a basic skill labs. In today's world, I know about 2018, we said we pushed this skill labs, and in COVID time, it was so relevant that people realize the value of these skill labs. Now, when we are now only talking about patients and the new normals were going to be different, today we are talking about augmented reality. We are talking about the virtual reality. I mean, about a week back, I was working with what is called as a holo medicine. It's like I'm sitting here and I'm talking to somebody, and I'm sure Sanjay will really get excited with all this technology, Sanjay and Chinmay. But holo medicine is something that they can see my face, they can see me talking, and I can move the skeleton very easily, even if I am from Germany or somewhere that way. So holo medicine, Microsoft Mesh, these are the new things which are coming up thanks to COVID pandemic, that we are now taking further steps into the skill development. What is important today in skill development is to contextualize it to our own settings. What did people really find? That you have a skill lab. Who will keep that record? Who will know, who will do that analytics that the student has really learned? All that can be done now, computerized. The teacher can only see the logs, and you don't have to really overburden your teachers. The students can do on their own, and they can contextualize it so that students learn, teachers need to see. Now that's going to be the future. So skill labs will probably help you gaining those skills which you need to do. And that's what is the future of this curriculum. Of course, elective is something where you normally get introduced to the research, the inquisitiveness in your mind. Maybe it's a small study you do, but that was an introduction of some kind of an self-directed learning. That was an introduction to the research. That was an introduction to the inquisitiveness. Need to consider top established versus new college. So we had to dilute sometimes the concepts of research. Assessment is the key. I won't talk much on assessment, but let me tell you, programmatic assessment, multiple assessment, subjective assessment, trying to do more formative assessments. These are the concepts which you need to go to various universities. And there are many universities which have taken a lead now, but we have to long way to walk. And I'm sure this will happen over a period of time. So what do we want future physicians to be? We want our future physicians to be balancing knowledge, technology, data science, and advances on one hand. On the other hand, we want them to be humanity, personalized care, shared decision making, because that is coming up today. The patients don't accept anymore that doctor says you do surgery. They will ask two other people. They will go to Google. They will find out what it is. They will give Google review to the doctor also, is good or bad. And communication. So if that is going to be a new normal, the new physicians have to balance this both. So we need to train them not only in knowledge, but we need to train them in all these aspects. This is part and parcel of our now career and progresses. So we cannot ignore that today. So future physicians have to be balanced into, we have to look for next few years when AI is going to come. When artificial intelligence, data analytics, all that is going to influence our practice. And people are going to look at your things. So if you are not used to this today, friends, I think you will not be able to face the future. So be ready. we have to start include this all in our curriculums. So there was a lot of criticism on our curriculum sometimes, maybe some degree. Is CBME effective? That's the first question people ask. Ye to sab ek aisa hi hai. You know, typical Ronald Harden's 3 questions, whether ostrich, bear, and somebody like that. So it's always there. Whenever you start new thing, there are always people who say this is not effective. It's okay. I mean, understand. What I think is the process is very important. The change in process is very important. People have to be woken up. You know, it's like a mother trying to try a new food item. You know, it brings a lot of cheer to the family. Whether that item may be the best, we don't know, but at least it gives some change. And secondly, it also helps you to really have that kind of an, what you call as food samskar, you know what we call it. These are not competencies, but objectancies. This was a very standard kind of a criticism. I also feel some degree, but that was the subject experts. And I'm sure we need to have EPAs and milestones developed for PGs as well as UGs over a period of time. I'm sure we will do that. But remember, in last 10 years, all these concepts developed got in the West. We are looking at it in 2021. But remember, these were prepared in 2015 when the concepts of milestones and EPA were not very clear. So now that they are refined, we may also have to refine some of this. Work and time overload. But as I said, we need to find out ways out by which you can reduce the faculty workload. And I'm sure people will talk about this. And teachers not willing for interactive teaching. I think most of the students like interactive teaching. They want themselves to be involved into teaching. You know, nobody wants to just listen. And I would like to always be part of my discussion with my student. So there's a continuous development and way ahead. There has to be a continuous process has to be there. You know, I would like to quote like that. Calvin Coolidge was very nice educationist who said, changing a college curriculum is like moving a graveyard. You never know how many friends the dead have until you try to move them. You know, it's a process by which many years go, many people die, anyway, whatever happens. But I personally feel we should continue to do this effort for betterment of our students. Now, what is the current status of CBME? CBME as a concept is getting accepted in the country. We have over a period of last 3 or 4 years, I'm sure we have accepted the concept. Teaching learning has changed, will change, I said, but this definitely changed. People have started using more interactivity. Thanks to COVID, people have started using a lot of online activities. People have started, there are a lot of apps have come, learning management systems have come. People look at it in a very different way. Interactivity should be part of your teaching. Assessment still needs a paradigm change. Need programmatic assessment. I'm sure there are few keynote addresses here. There are some sessions here and there are workshops on this. I would like you to really enjoy those workshops and try to make a change in your own settings, whatever at local level or a university level. We need to take more multiple formative and internal assessments. And most important is the embrace subjectivity along with objectivity in formative assessment. Don't throw away this subjectivity. I'm sure there's going to be a panel. At that time, we will definitely talk, but subjectivity is also equally important when we talk, but that can be accepted in an formative assessment. So this is a period of transition. You know what they normally say, that Nadi behti hai, wo wapas kabhi nahi aati. So this is a time which will never come. This was a period of transition. NTTC, FEMR, MC, all universities have helped us to develop this. Large-scale faculty development led to development of a critical mass. You know, that was the whole concept of FEMR. And many educators across the country helped us to plan this. Now, whenever there are reactions to curricular change, there's always initially difficulties adjusting to new approaches. I don't have the time, it's difficult, I don't understand the purpose. Then there's always a dip, and then there's a new improved performance where acceptance of the need to change, and there's a way to do it. And it's challenging, but I can do it. I think we need to turn over and make this happen, which has already started happening. I always look at this as what is called as a manthan. You know, I was always impressed by a movie in 1976. I don't know how many of you have seen, a lot of young people I can see. But this was a movie which made a lot of impact on me in 1976. This was a movie on Amul, you know, where they're trying to bring that milk. And it was a typical manthan, you know, Samudra manthan is another thing. But when there was a lot of churning, this came out. And there's a last scene which was very important. that the dairy kind of that supervisor leaves, but the local illiterate guy, he says, "अरे ये society अपनी है, ये हमारे लिए है." That is what we should all look at it. Maybe the concepts are from everywhere. This is our own curriculum. This is a curriculum, though it's a global idea, it is prepared by our teachers, implemented by our teachers for our own students. And this is for betterment for us. So we should always start looking at these curriculums for our own and try to embrace them. I always say, when I look back in last 15 years, I see pain, struggle, and frustration. But when I look into mirror now, I see strength, learned lessons, and pride. So this is back what I personally feel, that all of us go through this struggle and frustration. Remember, today we may be listening to faculty, courts, and students because they influence our curriculum today. But all of us are answerable to our patients and community because they are going to ask us, are you competent to treat me? Otherwise, they are going to leave us. So I personally feel all this approach has to be there towards making the patients more treatable and make them better. So I always like to say that there's something called as a tipping point. All of you should read this book on tipping point. It says that you have to work hard and have a slow momentum till you take this stone to this tipping point. Once you take this to the tipping point and you release, it goes on its own. And this happens, the conference. When you're starting on a conference, you have immediately a lot of pressures. Till the time, once it begins, I'm sure it is going to go very smoothly. So this is a tipping point at this stage of our curriculum. We have brought this to at this level. We are already launched, and I'm sure this is going to go ahead the way it is. I'm sure people will have it implemented. So to summarize, I think new CBME is not only curriculum, but momentum to change HPE for better. Don't consider only as a one curriculum. It's a momentum. As I said, it's a churning, which has happened in last 15 years. And the whole country has geared to change the whole thing. It's a collaborative work of many teachers. It will bring overall standardization with some creativity and flexibility and make us ready for future. And it's a curriculum for physicians of tomorrow. We have to balance not only knowledge, technology, but also humanity and personalized care. Because remember today, even if you grow in technology, we have a lot of variables. The humanism and humanity is not going to change. Doctors today also tell me that after 10 years, remember not how you treated me, but how you behaved with me. And that matters a lot. I think all of us remember those memories. So friends, I have to acknowledge many people here. Not only all the authorities, Dr. Paul and Krishna, Rajlakshmi, I told you is the strength. All my expert group members, our MCI support staff, all VCs, universities, DMEs, deans, all my experts. I'm some of the experts which I may not have taken name, but many of them have really helped me here. And of course, thank you for coming to this golden city. I think you have done a great job and wish you all the best. Thank you so much.
A very good morning to all of you. At the very onset, I would like to express my gratitude to the organizers of the conference for giving us this platform to share our journey and how we developed the skill lab and how the training is being imparted and how from starting in 2013, we have traveled to this point of time, and what innovations and what other elements we have tried to add over the years. So the presentation, as it says, the topic, Clinical Skills Lab, a step forward. So as Dr. Avinash Supe was sharing with you his journey of creating the new CBME curriculum, how with the Vision 2015, things had started changing. And with this vision document being published in 2012, we looked into so many new elements which were being brought into this Vision 2015. One area which caught my attention was the importance of the setting up of a clinical skill lab and imparting this clinical skill training to the MBBS students. So the idea stayed with me, and I was very lucky to take up this project as a curriculum innovation project and applied for FAMA fellowship. And in 2013, I got the GSMC FAMA fellowship with this title, Incorporation of Clinical Skills Training through Clinical Skills Laboratory as an Essential Tool in MBBS curriculum. And with this, the journey began. So here you can see that we like two clinical skills were picked up. So the first part was establishing a clinical skills lab. So what we did, we established a lab which had two demonstration rooms. We had a meeting room, and we designed a space for storing our mannequins. At that time, we didn't have enough space, so we tried to develop a space. A new area was created, which was later turned into medical education department, where we had all these small rooms, and also there was a big hall attached to this medical education department, where at that time we were conducting OSCE sessions. So it had a lot of students, they had to sit inside that near that facility, because the assessment was being done by using OSCE. So after setting up this lab, how we moved forward. So the pilot project started by selecting two skills. One was IM injection skill, the other one was nasogastric. So how I conceptualized, it was that the skill lab was made, one person, technical person was made in charge, and this the skill training, what instead of trying to give it only to the Department of Medical Education, I invited the faculty members for IM injection skills, anatomy department, and nasogastric medicine department. And that is how we began our journey. So in the pilot project, what we had done, we had taken up 30 students for IM injection skills and 30 for the nasogastric. And then later on, it was subdivided into three groups. One group having 10 students, because the skill training has to be given and followed by a practice session, because it has to be demonstrated. The students needs to practice under a faculty member who is going to observe it. And then later on, once the practice session is done, it has to be assessed using OSCE, and a checklist is also prepared. So while under taking up this project for 1 year, there were certain challenges, because what we had done, we didn't have any other time in the timetable at that point of time. So for the IM injection skills, we took up some part from their dissection hall time, which was allotted. And for nasogastric, when they were going into their clinical posting in fourth semester. So these were the few challenges which were faced. It was time constraints, and the faculty and the students had to accommodate the timing during their regular practical demonstration or clinical posting. And faculty also, like who had to go and train the students, they also missed their regular departmental work while they were at the skill lab. So from 2014, we started, playing with the ideas as to now how to bring about this change and how to implement this training into the curriculum, and then later on put it into the timetable, so that there is a definite, slot which the students have, and they will not miss. But then it was that since this was a small group training, so it had to, because if a few students are going, what will the rest of the students will do during that, if there is a particular slot? So we divided this 150 students into 3 groups, 50 going to anatomy, 50 to the biochemistry, and 50 to physiology, and then subdivided them so that they can have a smaller number of students whom the skill training can be imparted. The the other skills which we were teaching, they were picked up from their specific subjects like anatomy, like physiology and biochemistry. Some skills were identified, and then those skills were taught to all the students, and then there was a rotation. So every time we were finishing the pilot, we had the feedback, and during these sessions also, there was a feedback from the faculty as well as the students. And whatever was indicated, it was incorporated, and then we went ahead next year. So here you can see in the timetable. So that in the timetable, a particular slot was given so that the students can go and learn, do their skills training. 2000, yeah, this one. So here you can see that this is the clinical skill lab in yellow, you can see. So as I said, that feedback was taken from the students as well as the faculty, and all this was done because we tried to have 3 sessions in a week so that we could complete the entire training within a stipulated time. So here you can see the same thing, just move. So this is how we tried to create a module for a particular skill. So these are the basic steps which we tried to follow. So whatever skill was taken up, and the department, once it was identified, so we had a focus group discussion with the faculty members, and learning objectives of the clinical skills were defined, and formulation of structured teaching program was prepared. The faculty was trained for that particular skill, how they're going to impart the training. Preparation of student teaching program or blueprinting was done. Rehearsal of the teaching module by the faculty was done. And then the actual implementation of the teaching module was done. A checklist was also prepared to assess the clinical skills using OSCE. Training of the faculty had to be done at that time because some of the faculty was not well versed with how to conduct OSCE. And then assessment was done using a checklist, and feedback was taken from the students and the faculty, because every time feedback was taken, we went back and tried to make all those necessary changes. So here you can see the skill matrix as has been given by NMC, and it talks about all the clinical skills which are to be done in various phases, phase 1, 2, 3, and 4. So you will see that each department has been assigned a set of skills, which they have also tried to say that whether the skill has to be performed independently by the student, or it has to be observed, or it has to be only demonstrated. So, based on what is required for the student for that particular skill, the training module, or you can say that has to be developed. Can you move? So here you can see, because a lot of, the skills are shown in this slide. So respiratory medicine, psychiatry, radiology are only 3, departments where during their clinical, clinical rotations, no skill has been identified. Rest, all the departments are having a set of their own skills. So as I was mentioning that, if whether the skill has to be observed or demonstrated, or whether it has to be performed independently, these 3 things, if the skill has to be done independently, then as you see here, intramuscular injection, first it is taught in anatomy in the first semester, and at second level, it has to be done independently. It is done on mannequins using OSCE. So during internship, again, this has to be revisited because you have to give the certification for that skill. So what we do, we again try to teach the skill once again during internship, during the orientation program. And now, since it has to be performed independently, it is being done on a patient, and now it is being, assessed by using DOBS, because you have to see whether the patient, whether the student is now able to perform that skill correctly or not. So you have to, for making the student, perform that skill independently, the student needs to practice the skill a number of times, because only one time, two times you will do, you will not, the student will not be able to be confident about it. So in order to, have, get this, the skill training rightly and perform without do this clinical skills without, committing any errors or going wrong. This skill has to be performed at a number of times. So it can be, what we have done is that by doing this vertical integration through sequential learning. So here, the one skill can be started in MBBS first year, taken to the second level, and then moves forward. And at the end, these dots need to join somewhere to make a little sense. I will explain you in the next slide. So in phase 1, Department of Physiology teaches this skill of doing an ECG and its application and the cardiac axis. So it shows at the level of nose and knows how. Moving further, it goes to teach abnormal ECG, having arrhythmias, heart block, myocardial infarction. Again, the level is knows and knows how. And the third part is that record and interpret normal ECG in a volunteer or a simulated environment. And this is, at this point of time, it is shows and shows how. This is how you are moving slowly upward and trying to teach a student how to, from a novice, how he can move to a master in that skill matrix. So this moving again in the second and third phase, that same ECG skill performing, here you need to order, perform, and interpret also the ECG. First, you learn how to do the ECG, the normal ECG, and then order when you should order. You perform the ECG and interpret also at the level of shows and performs. Moving ahead, you have to order, perform, interpret an ECG in patients of IMD, MI, hypertension. Again, the level is shows and performs. And now moving further, these are some complicated cases because order and interpret diagnostic testing based on clinical diagnosis of thyroid disease, including ECG and atrial fibrillation and other things. So you should, the student should know he can have this and shows how also. And at this point of time, he should know that he has to refer it to a competent, a clinician. And similarly for this pediatric ECG also, he should know where to, till which point to go, and from which point he has to refer to a specialist. So these were the few lessons which were learned. So knowledge, from knowledge base to skill, from simple skills to more complex skills, skills being performed under observation and supervised, to performing independently, level of performance, which is related to expected task, as whether it has to be independent, observed, or demonstrated. So especially in because once he comes to the internship level and they are posted in emergency room. So during emergency situation, life-threatening situation, they have to perform, and they have to show how also. And at the same time, they have to refer whenever it is needed. So now how to, the skill labs which have been developed, how to use them? Because what we do, we try to revisit the skill which has been taught earlier. And as we move up into various phases, taking the same skill at various levels, so you have to go on adding new elements which are compatible at that phase, at that stage of the curriculum. So you can change the context, you can challenge the students, because now moving up, they have more knowledge. So the knowledge which corresponds to the skill, that now has to be incorporated slowly. And then later on, you at the same time, you have to apply holistic understanding of that particular clinical skill. You have to allow deliberate practice, give them time to practice all the new elements which the student has learned. You have to go on modifying the checklist to include not just single domain, but set of skills for that particular competency as you move up the new phases, so that you can align with the exit competency of the IMG. So sequential learning and moving, having a vertical integration will not only help the student to acquire that skill and have that, confidence when he goes out and starts practicing, so that he will make minimum errors, and he should have that decision making when to refer the patients further. So these are the few skill training programs which we have undertaken to try to share our experience with other medical colleges, faculty members, so that they can also set up their skill lab and start functioning. Because what is happening, skill labs are there, and but how to pick up a particular skill, how to develop the faculty, how to do the entire module and deliver the skill training, that part is missing. And we at ERA, along with my all my colleagues, we try to bridge this gap of establishing a clinical skill lab and actually trying to give the training to the students as the student moves up into various phases of the curriculum. So this was a short journey what we have tried to do, and my colleagues from ERA are now going to take up further this talk. And because most of the time it is thought that skill training, clinical skill training is the only thing which you can do in a skill lab, because now according to NMC, they have given guidelines for creating a skill lab. There has to be 8 cubicles which have a camera which is linked to a review room and various other components. So my colleague Dr. Nirmala Rege, she is going to take you forward with one more component of skill training, and which is very, very important, that is how to teach communication skills in the clinical skill lab. And then followed by Dr. Sucheta, who's going to talk about the innovations which we have tried to have at ERAS with the use of technology, how clinical skill training can be imparted, and then moving ahead, working in a team, how teams can be built and how all the health professionals can come and work as a team and treat the patient so that the patient receives better healthcare. So thank you very much. And for listening to this, I will now give the mic to Dr. Nirmala. Thank you.
Respected chairperson, distinguished faculty members, and my friends. I will be discussing with you use of skill lab for prescribing competency and communication and counseling skills. As you all know that there are 3 volumes of competency-based undergraduate curriculum for IMG, which have been published and they are available at NMC site. And there, the first volume mentions set of competencies expected to be achieved by an IMG at the time of graduation. And one of them is demonstrate ability to prescribe and safely administer appropriate therapies based on the principles of rational drug therapy, scientific validity, evidence, and cost. So we have to train our students for writing prescription using appropriate format, in legible handwriting, and they should be aware of do's and don'ts of prescription writing. And most importantly, they should avoid errors while writing prescription. There could be errors of omission, missing essential information, or there could be errors of commission, that is wrongly written information. And all these things has to be based on the rational prescribing principles. And one of the model which has been advocated by WHO in its booklet, Guide to Good Prescribing, is this 6-step model. And every clinician uses this particular model while prescribing medicines to the patients. And I would bring your attention to the 3rd step, that is selection, his or her P-drug treatment, and verifying the suitability. So every physician, actually, this they do, they have an inventory of effective groups of drugs for any given condition. From that, they select the effective group, and from that, a drug. Now, this drug is called as P-drug. That is, there may be 2,000 drugs which we learn when we are at 2nd MBBS. But if you ask any physician, he uses 30 to 40 drugs in his lifetime. So if this is a P drug, which is a drug of his personal choice, priority drug, which is prescribing regularly, he must be prescribing regularly. But the selection, though it is a personal choice, the selection should be based on effectiveness, safety, suitability, cost, called as the step approach. And in pharmacology, all this has been incorporated as a competency. So the students are expected to write, collect, correct, and legible generic prescription for a given condition and communicate it to the patient. That is at the level of performance, this particular skill. And they require a certain number to certify that, that is 5. They have to prepare and explain the list of P drugs for a given condition, and again at the performance level, and communicate it effectively, and then they are assessed, should be assessed at various skill stations. But what we want to tell you, that it has to be vertically integrated for strengthening this particular competency. It can't be just at the level of pharmacology. That time the students are understanding, they are learning pathology. And all of the clinician will agree, any therapeutics is based on the sound understanding of pathophysiology. At 2nd MBBS level, they don't see so many cases also. So there should be sequential learning in future phases, 3rd year, 4th year, internship. And the prescription writing can go through different stages, like patients with comorbidities, patients with organ damage, especially liver and kidney damage, patients at extremes of age, children, as well as elderly people, and the patients with concomitant medicines. And when we went with this, when we were preparing a prescribing skill module for online prescribing skill module at the level of ICMR, the ICMR group found that there are very few clinical, if you go to that volume 2 and 3, which is for medicine and allied and surgery and allied, very few competencies, they say it is to write prescription. It is in anesthesia, some of the competencies in internal medicine, orthopedics, but none of the clinical branches have mentioned writing prescription as a competency. They have said making management plan, but that is at the level of know-how and not even at the level of show-how. Whereas the prescribing goes for the lifelong period for that particular doctor. So again, I will repeat that it is not just the selection of appropriate drug, right route, dose, frequency, duration, which they learn in second MBBS, but they have to tell how to provide that information to the patient, how to start, monitor, stop the drug therapy, and how to instruct the patients regarding the drug use. And that has to be emphasized and reinforced by the clinicians so that our IMG can achieve that particular competency. Even this, in these competencies in volume 2 and 3, we have seen that there are preparation of documents has been mentioned as management plan and the writing prescription. That is one part which I told you, but informing patient about the optimal use of drug, conveying importance of adherence to therapy, advising related lifestyle changes, counseling patients, and the family education. And various common condition has been adopted in the different disciplines for eliciting and presenting history, counseling, or communication. And this is a good thing. And here we feel there is a judicious use of skill lab can be there. For small group teaching, on prescription writing prescription of simulated patient's interview, communication of prescription to the patient, giving instruction and warnings to the patient, and then counseling the patients or their relatives. And this, what Madam had said about the dots, what is started in the second MBBS level, those dots should be connected throughout to achieve meaningful exit competency on prescribing expected by the IMG. And this can be continued in the skill labs later on for the practitioners also, general practitioner, for continuing education program. Of course, there is a role of faculty member from all the clinical departments to identify the common conditions, not just the national health program, but there are conditions in the region, develop the case scenarios taking into consideration the level of the student, developing score system, at least writing 5 prescriptions whenever they are posted in the clinical posting, 5 times maybe in a semester, communicate prescription, and not to forget to give the feedback to the student and use as formative assessment. So based on this, in ERA, we try to develop the skill modules for communication. We use our skill lab with these different cubicles, and few are to give instruction or warnings to the patient who have been prescribed drugs, and they were based on making the students to do the role plays. So there is a peer learning. One student is behaving as a patient and the other student behaving as a doctor. Or many a times you will ask me, there is so much of patient load that we can't go on telling them everything. But it is a responsibility of the clinician ultimately who is writing prescription to communicate that prescription. And that has to be done in 4 minutes. If someone doesn't have time, then we can train the nurse, we can train the pharmacy, we can train our postgraduate students to communicate this. There are ways, but ultimately it is a responsibility of the prescriber. So the other person can play the role of any of the informant or the doctor. And that should be based on some checklist, which we have decided we will use this 5R principle, explaining them the reason, regimen, important risks, not just the list of side effects which appear in the textbook, which are the common one and which is the serious one where he has to come back to the doctor, revisit instruction when he has to come back, and certain revision statements that patient has to revise to remember what are the key things, and reassurance and interaction with the patients that can be reviewed by the faculty later on, and the feedback can be given to the not maybe individual student if it is not possible, to the group of students. And I will showcase to you one such attempt which we have done in the ENT department to instruct the patient who has been prescribed eardrop. One of the cubicle you will see this patient, that role play is going on. One student is behaving as a patient and another student is behaving as an informant. And he or she is explaining what has been prescribed to that particular patient by the another doctor. So we have made a checklist for this. This may not be an ideal interview. The students were practicing and we have taken it. But as I said earlier, the review can be given. It can be reviewed and it can be told the mistakes or whatever the errors students are making can be, the feedback can be given related to that. I will stop this presentation and I will show you that video.
नमस्कार, मेरा नाम अनुप्रीति है। आप अपना नाम बताइए। अहमद सालिक। अहमद, आपकी उम्र कितनी होगी? 22 साल। आपके पिताजी का नाम? मोहम्मद सलाउद्दीन। आप कहाँ के रहने वाले हैं अहमद? बालागंज से। किस दिक्कत से आपको आना पड़ा था? पानी निकालना। इसके अलावा आपको कोई दिक्कत? कान का पानी किस तरीके का? आपको पानी जैसा लग रहा था, कोई पीले रंग का निकल रहा हो, या आप बता सकते हैं क्या उसके बारे में थोड़ा सा? पानी जैसा था। कितने समय से आपको ये दिक्कत आ रही है?
I will take it a little forward, just because of want of time.
ये जो दवा दी गई है आपको, दवा आपको कब डालनी है? दवा आपको लेट के डालनी है। आप इस तरीके से लेटिएगा, करवट आपका इस तरह आप लीजिएगा कि जिस कान में आपने दाहिने कान में आपको बताया दिक्कत, दाहिना कान आपका ऊपर की दिशा में है। कान आप ऊपरी दिशा में खींचेगा जिससे आपकी जो कान की नली है वो सीधी हो जाएगी। इससे कान के बाहरी हिस्सा पे आप उंगली रखिए, जिसको आप 3 मिनट तक लेटे रहना है ताकि दवा अच्छे से जो है अंदर चली जाए। ठीक, और 2 की बूंद करके डालिएगा। ठीक है, 3 बार 2 की बूंद। आपको जितने भी स्टेप्स बताए हैं हमने, क्या आप समझ पाए हैं? समझ पाए हैं आप? ठीक है, आप एक बार रिपीट कर दीजिएगा जो भी आपको बताया है मैंने, आप एक बार खुद से बताइए।
ये जो दवा डॉक्टर साहब ने दी है, ये दवा है
जी,
और मुझे डालते समय मतलब दाने कान में डालना है तो दाना कान ऊपर रहेगा, करवट के कान से
जी,
करवट लेंगे
ठीक है,
और कान को बाहर पीछे की तरफ
ऊपरी दिशा में
नलकी हो जाएगी। उसके अंदर फिर हम ये 2 बूंद करके डालेंगे।
ठीक है,
थोड़ी देर हल्के हाथ में मसाज करेंगे और उसी तरीके से लेके रहेंगे।
जी बिल्कुल। 5 दिन। और कुछ जानना है इसके बारे में?
And then the other student starts writing the checklist, filling the checklist, and then they share with each other. I will stop at this, and I will invite my colleague, Dr. Sucheta Dandekar, to take it forward.
Thank you, Nima. So all of you must be wondering, how the hell are we going to do all this? Is it not? ये timetable है. There is the whole curriculum. There is the syllabus. We have to put all this into the 9 to 4 that the students are with us, because then the students have to also do self-study. Is it not? So it's going to be a Herculean task that all of us are going to face. What I want to tell you all now is, take you ahead and see what we have done at ERA. Small things we have tweaked and made it possible. Because remember, digitalization, technology, all this is going to come a long way. And our students are all the time tech savvy, is it not? So we have to hone those skills. We have to realize that zamana badalne wala hai. Aur jaise badlega, we have to take them in our stride. And that is what we have done at ERAS. What we did was, we have these, introduced these innovative teaching models where we have the edumation, which is where we have the animated lecture portal. Attached to the lecture portal, we have another portal which is involved with the assessment, the computer-aided revision and evaluation. Along with that, we have also got the medico skills, where we have the computer skills that are already ingrained in the whole system, and the gamification. So the cognitive skills we look into by having 3D animations. We have the medico skills, where the skills are actually done on the computer. So it is a whole software that has been developed. Then there is the evaluation of that whole process, and of course the NOMED. How do we check the psychomotor domain? There are the mannequins. There is the skill enhancer and the learning foundation, that is the self, and we also have the medical video games. All this is in place as far as the main IT hub is concerned. So we have the smart mannequins, where the students have a checklist as to what to do as far as the clinical skills are concerned. And then the mannequin is programmed and attached to a device, which indicates, what particular step has to be performed and whether the person is performing it correctly or not. And then the student can practice repeatedly till they master the skill. We also have these medical animations and the video games. So what happens is, the student goes through this entire process through a game. So this gamification has a very, very kind of a fun attached to it. And the student is able to keep on repeating the skill. And this medico skills, see, we have each and every student who enters the premise of ERAS is given a user ID and a user password, including the faculty. There is an onus on the faculty also to develop a sort of a plan. So the faculty thinks, and the IT personnel then actually put it into the code, and we get it all done. So when the student has the user ID, he clicks on the user ID and selects a topic that has to be done. There are subtopics, and then you will notice here that there is a percent. After he has done the skill, he gets a percentage marking of how much of what he has achieved. After that, he is also given a status of whether he has passed or failed. Once that happens, it is a log that is maintained, so that the number of test attempts that he has done also comes back to him. So this is all, as Dr. Supe told in his lecture, that time has come when there has to be a lot of hand-holding. It is not just the teacher who's involved. It is the student and the teacher who will come together. So the student of course, is also motivated enough because he is enjoying this process. He's saying, "Arey, ye to maza aa raha hai. Dekhte hain kitna attempt hai." And if needed, the teacher can have a look at the scores, but if not, it can also remain with him. So, it's the way in which the practice happens. And there is a test date also. So the student is aware how many attempts he has taken to achieve a certain kind of a goal. And then the tests are assessed, the skills are assessed. What have we achieved with all this? First of all, there is a synchronous skill assessment. Secondly, it has resulted in a reduction of the costs of hiring multiple trainers and evaluators, and of having someone hovering over the student to see, kar raha hai ki nahi kar raha hai. Yes, because it's just documented and the student is self-learning. There is a real-time self-study platform. So you realize this. And there is a maintenance of a time-stamped performance database. So the teacher and the student is aware of this. It is digitally validated. And of course, after the whole process is over, the student is able to get a system generated certification of what he has achieved. So remember, whenever we do anything and you're assessed, and after all that, you get a certificate, there is a feeling of happiness, is it not? I mean, abhi aap bhi idhar aaye ho, you have attended this conference. When you go out, if you get that certificate in your hand, you will feel happy. Ki chalo, my points are also added and I have got a certificate in my hand. So psychologically also, all this works in a very big way as far as the whole teaching learning process is concerned. We have the teaching platform. I have used this multiple times at ERAS, and I'm so happy with it because it gives me, I don't know whether you're able to actually see it, but I have a user ID, I have a user password, and you have the subjects and you have the topics where you have the video lectures there. And I just have to click. If I want to, I'm a biochemist. So if I want to teach lipoprotein metabolism and you know how complex things can get at times with all the apoproteins, etc., playing their own game, and students find it very difficult to comprehend. So what I can do is I can show them this video to see what is moving in and what is moving out, and they enjoy the whole process. And the best part is I can pause that video to say, now this is what happened, and I can interact with my students to say, what did you see or what did you notice as far as this lipoprotein was involved? So things are so much better and people, and the learning is fun. This is one more snapshot of what we do. And this, ultimately, whatever we do, remember, assessment is very important, and formative assessment is important, because ultimately, if you're not able to, have the students continuously assessed, we have problems. You may feel, how many books are you going to correct? 150 students, 200 students, 250 students, unki kitabein aati jayengi, and then you feel, then you sort of feel drained of energy. But if you have an app which is given to the student on their mobile, and if you give them questions as far to answer on the mobile app, they don't mind answering at all. And there's a log kept, of course. See, ultimately, there's no need for you to have some freedom, absolute freedom to the students. So we make it compulsory for faculty and the student. This app is called CARE. And what is the CARE an acronym for? Computed Aided Revision and Evaluation. We are trying to tell the students we care for them. And how do we do it? Each student, each faculty again has a username and a user ID, and they go onto the login page, and just before my lecture or after my lecture, I put in the questions that need to be answered after, related to that particular topic. What I do sometimes is I put the questions before, and I tell my students, aapke mobile phones leke aaiye. All right, so they're so happy that the mobile phones that I can actually use my mobile phone in class. Oh my God, that's the most wonderful thing that could have ever happened, is it not? So, and at that time, I use this to introduce interactivity in my class, where I give them these questions that are already prepared, and it can be used for revision, evaluation, as part of a study material. And I give them these questions. And there is a scroll down system where I could ask them just fill in the blanks. There could be swap cards, there could be labeling, there could be arranging in a particular sequence or a flow chart or just plain MCQs. So this can be used to introduce interactivity in the class, where I can just show them the MCQ and I say, chaliye, now answer this. And it works. It works very well. Students are very happy that they can, touch their mobile phone in class, and they just go ahead and do it. And this is the example. I won't spend time just, but to just say, tell you how we use this whole system. So remember, and then of course, they also answer it after the lecture is over. And that is a compulsion. You can't, give a lot of freedom to the students. And it's a binding and a compulsion also for the, sorry. So there is, we can use this for both. During the teaching also, for interactivity, and we can also use it as an assessment tool. So remember, as far as innovation is concerned, that there are 5 ways to organize innovation. And I feel that the leadership is also of great importance, that leaders encourage innovation. Here, when I say leader, I don't mean management. I don't mean Dr. Farzana Mehdi. I mean us. I mean all of us who have to be motivated enough to put all this into action. And once all of us realize the importance of using this technology to put it forward, we sort of form a culture of innovation. And then there is a formal innovation strategy that comes into place. So all the departmental people are involved in this. If I forget to put my care questions after my lecture, I get a phone call from the office. So there's one dedicated person who says, Madam, aapke questions nahi mile. Madam, aapke questions nahi aaye. So I have to say, oh yes, I got busy, sorry, I have to do it. So there is a hand-holding also. And it's not a mean and a rude kind of a thing. It says, Madam, please dal dijiye. And it happens. So remember, with all this, let us not forget the commercial angle. That is where the leader or the management comes in, where you need to have a certain amount of budget that is kept aside. And then the leaders are able to then give direction so that all of us are on the same page, and we can then move forward. So in the words of Ken Robinson, the role of a creative leader is not to have all the ideas. It's to create a culture where everyone can have ideas and feel that they are valued. And that is when all of us together will do a hand-holding and move this entire CBME forward. With that, thank you very much. And now I invite Dr. Anuja Bhargava to tell you of how we can take this forward as a team, and we can move it with interprofessional education. So over to you, Anuja.
Thank you so much, ma'am. A very good morning to all the esteemed audience. And this is in continuation with something Supe sir told us this morning. I think all of us sitting in the audience would agree that taking care of a patient is not going to be done alone by the doctor. Like sir gave us examples, it could be diseases, hypertension, epilepsy, vertigo. We can just go on and on. So with this, we take forward interprofessional collaborative skills training. I think COVID has been an experience. And I think going back, we were here in this same room in the month of February last year. There are a lot of memories which are flowing, but the last 2 years have been difficult on all of us. So what do we remember? We remember COVID. And I think the first picture which comes into our mind the minute we think of COVID is of a healthcare professional in a PPE. Did we know who was taking care of our loved ones? Was he or she a doctor, a physiotherapist, a nursing staff? Could have just been a sweeper for that matter. But that person was providing care to your loved ones when you could not approach them. So we learned out of COVID that patient care needs collaborative practice. Now, coming to the Indian medical graduate, what does the Indian medical graduate need? Team skills, leadership skills, which come by immersive simulated learning environment, which in turn are imparted by interprofessional collaborative skills training. Since morning, we have been talking about a journey. We have been talking about since 2004. This is 2021. And we know that as the years pass by, the IMG is evolving and the needs for the IMG are as well evolving. So with this, we share our experience at ERA. We started a project with Mahif Fammer as a part of my fellowship. The module was developed for the procedure of tracheostomy. I think we would think the minute you think tracheostomy, you think of an ICU, think of an ENT specialist. At maximum, we think of an anesthetist. Do we think of the nursing staff? Do we think of the OT technician, the trauma technician who's passing you the instrument, the tracheal dilator? Do we think of the educationist who made this module? Or maybe a statistician who helped us? So there is in toto an IPE team which is working together to improve patient care. Now, once we had our team in place, we designed our curriculum, defined our learning objectives, laid down our teaching learning methods, our evaluation methods. I would like to highlight and draw everybody's attention here. We sure agree that when you are in a teamwork, there's a very famous saying, too many cooks spoil the broth. But that's not for patient care. When you have an ambulance coming into the emergency and you're receiving a trauma patient, we all need to know what we are supposed to be doing. One of us has to be giving the airway, the other one has to be stabilizing the spine. So we all need to know what our roles are. That's exactly what we did. We used a questionnaire based on McMaster-Ottawa scale, and we took the IP competencies and made the questionnaire for everyone's roles, for the ENT specialist, nursing, physiotherapist, OT, trauma technician, and so on and so forth. It could be possible that if, as an ENT surgeon, I was doing something, I was counseling the patient, my nursing staff could also be doing the same. So we were doing that again and again. This particular questionnaire was validated by internal and external experts. So now what we have a module in place which has been implemented, and these were the outcomes. Now, when we get to work together, I think most of us as clinicians, as Sir said in the morning, there would be a lot of arguments and we have to come to a consensus. So we learned how to give patient care in a team. The faculty and students were sensitized to the concept of interprofessional collaborative skills training. Now we had an IPP team, interprofessional team, that was more confident and motivated. Now the team members working together showed more collaboration, effective communication, and clarity in role identification. This module is ready for use for future teams, not only for tracheostomy, we'll be taking it forward to other procedures as well. And what about a patient? The patient will now have improved patient care, not only during tracheostomy. It's very important to understand what is our goal. The goal is not doing tracheostomy. The goal is to save the patient and have him healthy after decannulation. And that we would be able to achieve by a team. So, improved healthcare in society with moving beyond silos, beyond a compartment, towards interprofessional collaborative practice, shared leadership. As ma'am already said, Suchita ma'am, we don't have to think that my Honorable Vice Chancellor is my leader. She always inculcates into each of us that you are a leader in yourself. That's shared leadership. She gives us that you have the onus. Yes, you can do that. She always entrusts that confidence into us that you can do it. And of course, community practice. With this, I would now like to invite my Honorable Vice Chancellor, Dr. Farzana Mehndi, for our concluding remarks of the session. Thank you.
So, thank you, Dr. Anuja, Dr. Sucheta, Dr. Nirmala. So, as in the beginning, I talked that we are going to take you through the journey, and we're going to show you various aspects of acquisition of skills, be it clinical, be it communication, be it building a team, and how to work as a team for the betterment of patient. The entire this IMGs, they are being trained to deliver healthcare services, better healthcare services. So just one more example, which in which technology has been used for to better the patient care. So what we have done during COVID, when the residents were going and they had to do various procedures in the in the wards, and clinicians were not present there.
Frequently develop hypoxia and thus require orotracheal intubation. This procedure is carried out by using a device called laryngoscope. Currently, a video laryngoscope is recommended for airway management during COVID-19 process. Commercially available video laryngoscopes are costly and difficult to acquire due to decreased demand during the pandemic. Also, there is a lack of personnel trained in using those video laryngoscopes. So we have designed a laryngoscope which is cheap, easy to use, requires no specialized training, and can be used in a similar way like conventional laryngoscope. We have used board-scope HD camera with LED lights, which is attached 4 centimeters distant to the tip of the laryngoscope, which can be connected to any smartphone or tablet via USB Type-C cable using camera Fi app. The live images can be transmitted via Wi-Fi to control room, where intensivists can monitor the tube passing through the glottis. This helps in immediate detection of the tube displacement, and this will prevent the airway-related deaths. This video laryngoscope can also be used for Raleigh tube insertion by expert guidance from the location, early detection of misplacement, and confirmation of ET tube position, real-time teaching of procedures to the junior staff at remote locations. During the current COVID-19 pandemic, where the use of PPE and goggles decreases the visibility, the use of this device will prove to be useful, especially in resource-poor countries where expensive video laryngoscopes are not easily available.
So this has been developed at ERAS, and we have also filed for the patent, and so that it can be made available to other institutes as well. So thank you very much. And I would like to say that a few more minutes we had taken extra because 4 of us were there. And so kindly excuse for that. And thanks for patient hearing. Thank you.
Good morning once again. This morning we heard Dr. Avinash Supe telling us about the various components of competency-based medical education. And I think one of the best things to have been added to the new curriculum is the student doctor method of training. During our times, that was the way to learn medicine. Somehow in between it got fizzled out. But again, missing out what the students were not able to learn, I think this renewed interest is going to be very useful. Now, since it's a relatively newer method and not many people have experienced it either as a student or as a teacher, there are a lot of, I would say, communication gaps happening between what was intended and what is actually happening at the peripheral sites. Now, we're fortunate to have with us Dr. Krishna Sheshadri, the person who I can unofficially tell you was responsible for designing the student doctor learning module, which all of us have been reading on the NMC website. And I requested him to kindly enlighten the audience on the various modalities, what is to be done, what is not required of that method, and so many other things and so many other questions which many of us have.
Thank you very much. It's really my pleasure to be here in this golden city that has been in the vanguard of protecting our civilization for so many centuries. I think the history that surrounds this city also is a good way to remember the history that of medical education, the way we have grown. Remember that for centuries, doctoring was apprenticeship. You went to a teacher, a master, a guru, and if you, I don't know how many of you read Bhagavata or Charaka or Sushruta, but we have a long tradition of apprenticeship. For some reason, we moved away from that apprenticeship and learning on the move and learning on the work to being who we have actually morphed into in these COVID era, which is basically a chair potato and just knowledge becoming more important than doing. This was an attempt that I think we made to change this. First, let me acknowledge some mentors and colleagues here. I think one is sitting in front of me, Tejinder. The other's name is seen right on my presentation, Avinashu. The third one is Dr. Rajalakshmi. What they did was, I was a maverick with a lot of ideas, and they ground me and polished me into a way that I could actually gain some of that wisdom, some of that balance that is required to help shape some of the things that my colleagues and mentors have helped really, they were the ones who have created this beautiful curriculum. If you look at it, it looks so imperfect. And in being imperfect, it represents each one of us. Our beauties, our warts, our ugliness, our defects, but it works. It works because we all want it to work. So let's start with this. What is the purpose of clinical teaching? And this is NDA in 1983. The purpose of clinical teaching and training is creating an expertise in the care of the patient. And I emphasize in two parts of this: expertise and care and patient. Remember, as much as we are so obsessed with our subjects, the obsession of this learner must be the patient, because more than 95% of our graduates will ultimately take care of patients. So even if you are teaching anatomy, physiology, biochemistry, pharmacology, remember that those skills are there to make this a better caregiver for patients. I think that's something that we need to keep reminding ourselves all the time. So clinical instruction is a teaching, a learning interaction between clinical teacher and student, which normally occurs in the intellectual vicinity of the patient and focuses on either the patient or some clinical phenomenon which concerns a patient or class of patients. And I think this is again key, because then we understand why the apprenticeship model works. You learn through experience, you reflect on the experience, you have a mentor or a guide who helps you shape that experience into your practice, and then you go on to the next one. And unless you have longitudinal follow-up, you don't get to do this. What are the pitfalls that we know of clinical teaching? One is there's a lack of clear objectives and expectations. And it's very important, while we focus so much on CBME, and you will notice that in all the education groups that we have, that the focus on CBME seems to be in the first two phases. The expectations, the outcomes, the objectives are not so importantly focused in the third phase and internship, where actually they need to be even more focused. And Avinash talked about this morning, from what we need to start moving to why, how, and why not. Third, we assume too much. We pitch it at the wrong level. It need to assume the more critical it is, the more fundamental, the more basal we need to look at. I'll talk about history taking in a while, because it is such an underrated art, and it's a completely unobserved art. Passive observation, then active participation of learners. This slide is 17 years old. I've been using this slide for 17 years. Of course, inadequate supervision and feedback, very little opportunity for reflection and discussion. Of course, we love to teach by humiliation. We think we are Socrates reborn. We don't understand that our students are not Socrates' students. They're not Plato or Aristotle, but people like you and I who get offended very easily. But it's not a question of getting offended. They also retreat very fast. Of course, patients are an important issue, that we use patients often to teach the wrong things. We don't, and of course, these are important. But importantly, there seems to be a big disconnect between what the curriculum wants us to do and what is achieved in the words. Of course, can't blame them, because most teachers are doctors. They're taking care of patients. That's what they're supposed to do for the most importantly. There is a competing demand, so they can't spend that, or at least they will tell you that they can't spend that much time designing curricula. Actually, they can. And of course, it's opportunistic. It is seminal. The patient that you want to prepare for doesn't walk into the OP every day. Of course, there is so much disconnect. For example, for many years, internal medicine was all about teaching mitral stenosis and mitral regurgitation. And then you had to go out in the world and then see diabetes and tuberculosis, right? But what was the issue was that it was not planned. And of course, this is the excuse that all of us give, increasing number of students. But there are some new challenges. There are fewer patients. Many of them don't come to large institutions. The pandemic has also ensured that patients stay away from hospitals a lot. Of course, under-resourced, don't have the kind of stuff that Dr. Tandekar and team just showed, right? More importantly, the environment is also not very teaching friendly. Because teachers are the last people anybody wants to recognize. So what are the desirable outcomes in clinical settings, right? There are some core skill sets, but I can tell you even this, we do some stuff wrong. For example, while we emphasize a lot on physical examination, many of us don't watch our students examine. While history is important, none of us have watched our patients take the history, right? But it's also important how data is collated and prioritized in this. Data is the new oil, right? Data is money. And today data is everything, but our students don't know how to organize and collect data. Forget the management plan and but there are additional things that you learn in a clinical care setting. How do you work with a team? How do you work with nurses? How do you work with pharmacists? How do you work with phlebotomists? How do you treat people the same way? Most kids who join a medical school come from mollycoddle families where, and also single child or double child families where they don't interact with cousins and others and learn how to work with teams. There are professional values and how to work within a system. Then, of course, there is a continuum of growth, a continuum of becoming a little more sophisticated each time, moving up the Miller's pyramid, but also realizing personal goals, realizing their own personal potential, and of course, getting skills for lifelong learning. You don't want to give fish, you want to give a fishing rod. Again, Avinash showed you this in the morning. It's also important to understand that when you look at these domain docs, as I call it, knowledge, skills, attitudes, values, responsiveness, and communication, right? The teacher seems to think that this is important. When you become a doctor, you see that that this space shrinks a lot and this becomes important. And this space expands. But look at from the perspective of the patient, it's more than knowledge, it's accessibility. It's a little bit of skill, but it's communication, responsiveness, and attitudes. From a society's perspective, it's values. But these are things that can't be done in a classroom. And I can tell you that the clinical teaching as was structured was classroom teaching. The only thing was there was a passive patient who was sitting. I remember many years ago walking into our OP. I would go at 7:30 to pick up the case. One of the 20 people in that room, one person would have examined the case. The diagnosis would have been told by the postgraduate student who picked up the case for you. The professor, and I remember him very well, wonderful man who just died, who walked in at 8:15 sharp. The postgraduate will whisper to the assistant what the case is. The assistant will whisper to the chief what the case is. Then he will sit down and then he will look at the patient a little. He will cock his head a little, nicely, beautifully. And then the first 3 lines will be presented by the person who's presenting. The girls will form the first 2 rows and we will all be craning our heads over them. But, it was a nice experience. And then what would happen is, after the 3rd line, the teacher would start dictating notes. 30 causes of clubbing, 15 causes of tuberculosis. Today, clinical teaching is still a classroom teaching, right? So it's pitched strong. It's pitched at the wrong end. So let's take this forward. So what are the next pillars of the next generation school? We talked about this today. Sequential competency alignment was beautifully brought out by the ERAS team. Team-based performance assessment, care, safety, outcome, and accountability. Economically sustainable, diversity that's globally focused, learner and learning focus, competency and outcome-based, simulation and vertical pedagogy. But I'll tell you this, that this is very important. That cannot be taught outside of an immersive learning setting. It cannot be taught outside of an immersive learning setting. This cannot be taught outside of an immersive learning setting, nor can this. So just to take this forward, so remember, what is the process of competency derived education? And then I will move on quickly to this. One is competencies are determined and these are aligned to the mission and vision of the training program. If it's not aligned, it doesn't work. Second, the outcomes are stated and communicated to everyone. Communication is the key. The student or the learner knows, and he really needs to know what he needs to check off. The way I look at competency-based education is you have a bunch of things that are kept in a supermarket counter. The learner has a checklist of things that he has to put in a shopping box before he checks out. There are people in the aisle who are the teachers who tell you, you know what, this is the way you can go get this. If this is an easier way to go get it, this is the right way to go get it. But ultimately, he needs to have it in his basket. And then when he goes to checkout, the checkout clerk tells you, okay, you've done this, you've done this, you've done this. And instead of him paying, you pay him and say, you're ready to go out into society. So really, this supermarket idea is something we want to think about. And that brings us the importance of shared responsibility. And the learner-doctor method is a very, very important way of looking at shared responsibility. So look at this as a person who's going through this. There is the achievement and outcomes are ascertained and documented. There is proof of acquisition of selected competencies and achievement of outcome. This could be a summative exam. But also, there is an achievement of determined standard and periodic assessment. And there's a documentation of acquisition and predetermined skills and values that is done by both internal assessment and a logbook with a supporting document. So what we're doing is going from TCP into ultimately acquisition of these competencies. And it means that the driving force of the process has to shift from the teacher to the learner. The second, the responsibility for the content has to become the teacher and the learner. And knowledge application becomes the important part of this whole process. Right? So this is the change in focus. Responsibility, collaborative, learner-centric, skill acquisition and certification, and formative assessment as an integral part of the learning process, and progressive increase in complexities. So does the learner-doctor method achieve this? So first is to look at the NMC definition of this. The learner-doctor method of clinical training is a part of the clinical rotations of the MBBS course. So it's not anything separate. It's not a standout. It is part of the clinical rotation. This is one. It is longitudinal. It is immersive. It includes the care of the patients in a supervised setting. So these five, the definition sort of tells you everything. One, longitudinal. Two, immersive, which means you're doing as you learn, right? It has to be focused about the care of the patient, and it has to be supervised. These are the 5 prerequisites for this program. What can he learn? What can the learner learn from a teacher-doctor program, right? So first, the 3 things that are important. One is longitudinal care. Second, immersive learning care in the patient care environment. The patient is part of the team. Importantly, application of how to gather data, how to document, how to present. 3 critical skills for a doctor are really achieved by giving them this thing. Then learning in the environment. How do you work with a team? How do you work in a system of practice? How do you continue to learn based on seeing developments in the patient? For example, you know about pneumonia, but here is a patient with a variant of the pneumonia. So how do you add that piece of information into your basket? How does it modify my existing understanding of this problem? So how do I react to a problem that comes with a variation? So that's progression of learning, right? Critical thinking. One of the things I remember most from my residency in the US is having a medical student who tagged along with you. We used to call them the short coats because their coats were short. And one, they would have their Ferris, and the other, they would have the Washington manual. They would be focused on this, and they would see the patient, and they would write long analysis. My teacher, Dr. Shagran, would not accept an analysis that is less than a page and a half in the case sheet, and that was the risk that the institution took. They allowed the medical student to write in the case sheet. You can do that, as long as you corrected it and you signed off and you agreed or not agreed with it. And Dr. Shagran would come the next day morning, ask me to write a note, and then he would write agree and sign after reviewing it. And then he would take the student along to the side and review that analysis and talk to him about it every day. Right, professional growth and decision making, right? There are some other things. You learn about how to work with patients and families. You learn about how to work with people. You explain. You understand somebody has a resource constraint. You bring that back into practice. I want to add this is called the bit on patient safety. Most of us don't talk about it. The importance of patient safety can't be learned in any other environment. Sustainability, and then of course, risk for diversity in opinion, in culture, and values. Respecting a patient who says, look, I can't do this. I don't want to do this. I can't take a blood transfusion because my values don't allow me to take it. How do you work with that? It's done by working in a team. And of course, remember that you still have to get all the competencies. So you want to make sure that there is room for loggable and non-classroom competencies that your peers have put onto you in those 3 big volumes. You still have to achieve it, right? How do you do that? Some of it here. Lastly, my favorite part of every rubric or every construction is, I'm happy not to teach the curriculum, but I'm very happy to teach values, ethics, and empathy. These are the most important things that students learn when they're in an immersive environment. What else can they learn? All your bad habits, the arrogance, the ego, the shortcuts, the gaming of the system. They will learn all of those because you will be their models. So it's a good way to have a student tag along, because you'll become a better doctor and a human being, and you'll act like one. Remember the rules. You'll realize, we go back to it. These are the things that we thought we should have. And remember, the communicator bit was something that's very new in this whole role business, because in fact, you'll see that we are the only curriculum that has communication as a separate domain. The reason is we realize that this is the key to the advancement of healthcare in this country. Right. So how is it now? First thing is just to disabuse people of this notion. At this point of time, I think the way the GMER is structured, as well as from a conceptual point of view, we really don't want this to happen in all specialties. Just medicine, surgery, OBGYN, and pediatric and ortho, because these are basic specialties. These have a little more faculty, a greater amount of supervision is possible. And second, there are some constraints. For example, the very interesting thing that we noticed. For example, when this was originally thought of, there are some models in India where students stay the whole day, right? There are people who already had clerkships. But the issue is something very simple. Let's say there's a college in an Naxalite affected area, right? Is it safety for all your students to be there at 11 o'clock or 12 o'clock at night? No. Do you have campus residence for all students all the time? We don't. So one of the reasons that this was a 6 p.m. only stop, and some of the restrictions and some of the initial starts were because of what Avinash talked about. It. This can't be for an elite group of institutions. If we do that, then nothing will be followed. It had to be for something that every college can do. We didn't want to sacrifice the good in the altar of the ideal. So why is it not such a perfect program? Because we're not a perfect country. So the student is achieved. First important is make sure that they are oriented. They know the expectations are known. One of the things that we envisaged during this was that every student has a designated faculty member in charge. It could be the lowliest assistant professor in your department. It could be the senior most resident in the department, doesn't matter. But you need a person in charge of that student who is providing the guidance to that particular student. That's very important. Second is that this person is generally the person in charge of the patient, who makes decisions for the patient, who can review the notes, who can review the discussion, who can listen to the discussions of the student and make sure it's there. So this is the important part. Second, the student is part of the team. I'll re-emphasize this. Student is part of the team, which means he or she has responsibilities, correct? So that he or she also has opportunities. But it also means that the team protects the student. I'll tell you, when I was posted in the ward and as an intern, what would the nurses do? They would ask you to write the pharmacy intent. That's not the job of the student or the intern. That's the job of the nurse. Right? If there's a transporter for the phlebotomy samples, the student cannot be the transporter of the phlebotomy samples. That's not the job of the student. That's the job of the phlebotomist. If the person has to be transported to the MRI, the student can accompany to see how the MRI is done, to help the patient along with it. In an emergency, he can push the cart, but the student is not a cart pusher. He needs to have the dignity of being a member. I'm sorry, I'm being hard and harsh on this, but this is a place, these are vulnerable people who should not be abused. So they need to have responsibility and they need to have the opportunity. They are not there for scut work. They have to be assigned admitted patients. They have to interview, examine, work up, and follow. Remember, always under supervision. They are asked to remain in the admission team until 6 p.m. on the admission day, except during designated class hours. If they have to go to a class, you have to let them go to a class. Right? Next. They participate in patient care rounds. And let's say the chief is coming on rounds. Then when it comes to this patient that this is important, the chief must be told, sir, this was worked up by the student. I would like him to present. Right? You can't be so at least if you have, let's say you have dedicated teaching rounds 2 to 3 times a week, when it comes to this particular student, then they take care of it. I think it's very important to understand this part. And of course, we've asked for participation in team rounds on at least one other day than the admission day. So despite everything else, so one day of the week and the post-admission day is designated where these people actually go in the admission rounds. And of course, there's a progression increase in the skills that they do. Do not, just because you have a student, don't burden them with the things that they shouldn't be doing. Again, I'll keep doing this. Then, present the assigned patient, participate in team activities. You can have them go on the nurses rounds. You can have them go on the multidisciplinary team rounds. You can have them, give them tasks to do and write in the case sheet and then put it in the log. Fulfill the learning responsibilities assigned based on the clinical learning and context. But remember, every institution should set for rotation 1, these are the competencies that have to be achieved. For rotation 2, these are the competencies that have to be achieved. Remember, the focus needs to be on the student achieving those competencies and not just to give them a varied experience or just getting them being part of the team. Document is important. The patient encounters and learnings appropriate to the level of documents are noted. Let's say a case sheet is written or just a history taking is recorded and kept in an e-portfolio. Or a counseling session is recorded, depends on what the competency needs to be achieved. The log is initialed by the supervising physician. Whoever is supervised the patient initials it, logs it, and that's part of it. But it's a planned activity. There are unplanned activities that can go into it, but the majority is planned activity. Right? So how do you, for example, data gathering? Get a detailed history and physical exam, put it in a case sheet, have it signed, log it, or you have a lot of institutions who don't want it in the case sheet, you can have a shadow case sheet. You create a shadow case sheet, keep it in the case sheet, and when the patient gets discharged, take it out and put it in the portfolio. You have a patient, let's say with diabetes and leg ulcer, you can have them write a reflection. What are the contributors to why has this patient developed a leg ulcer, while a similar patient with the same A1C has not developed a leg ulcer. Patient can go and get a history of foot use, of non-compliance, of a whole bunch of things. And that can be an analysis, so write an analysis. The student can actually write his own management plan, and then he can find and discuss, okay, this is the plan that I wrote, but this is what was done. Why was this done? Was it because the patient can't afford it? Or is it because there are better options available? Is it just patient preference, right? It's just a question of expanding our horizons. Then how to use the formulary that is available in an organization. How to use, how to work with the things that you have. Please let me know when I have to stop. And of course, communication, we've talked about all of this, but it's very important. An assignment can be given saying, you've seen this patient. We have used this particular antibiotic. How have the guidelines changed? We used packed red blood cells in this patient. How has this changed? This is important. Just a few more. So what do students need? Let me emphasize on certain things. One is they need an environment where they believe their attitudes, their behaviors can be observed, analyzed, and challenged. That's what these rotations are for. If you don't observe them, then everything falls off. Observation is the beginning of understanding. On rounds, why go around one day a little early? Oh, this patient's been admitted. You know what? Why don't you talk to the patient? I'm just going to sit here. Just sit, don't intervene. Then come back. What went well? Can I give you a little bit of feedback on what you should have done? Maybe you were asking questions from a list. Why not let the patient speak? Don't give feedback in front of the whole team and make this person feel miserable. On the other hand, appreciate the student in front of the whole team. So this is my favorite quote. This is from George Engel. If musicians learn to play instruments as physicians learn to interview patients, the procedure would consist of presenting lectures or maybe in demonstration, the theory and mechanisms of the music producing ability of the instrument and telling him to produce a melody. The instructor, of course, would not be present to observe or listen to the student's effort, but would be satisfied the student's subsequent verbal report of what came out of the instrument. This is exactly what happens. Even in an examination, a student is not observed taking a history. The examiner sits in one corner with murukku and biscuits, and the registrar has already told the student what the diagnosis is, right? So quickly, how do you create a learning environment? First is choose competencies that can be given in this learning environment, right? So for example, I've used diabetes as an example. In year 2, elicit and document a medical history of someone with diabetes. Year 3, the same. Let me show you that one. So here is on the first year, they could write their nutritional history, their family history, the medication history. Second year, they could elucidate more things like precipitating factors in lifestyle, the influence of comorbidities and or target organ disease. So can you see the same internal medicine competency, how it progresses into 1, 2, and 3. Remember, this is very important. The learner doctor method is not an unplanned activity. I want you to be clear about this. These need to be done before. Second, determine the activities from the competency that can be done in that environment, right? Make sure you have a mix of activities. Third, do not use it in lieu of a skills lab, right? Here, observe the presentation, assess the case record in a portfolio, validate the logbook entry of somebody eliciting, documenting, and presenting. Somebody documenting and presenting a systemic examination. Ask them to do a urine ketone or a dipstick. You don't have to do it. A nurse can do it. A nurse can supervise this. It doesn't have to be a doctor all the time. A nurse can supervise how after he has gotten certification from the skills lab, how to give a insulin injection. Right? Provide time for reflection. I don't have much time so I'll close, but provide time for reflection. This is again, an area where I keep pushing this, but you want them to explore the experience. What went right? Yesterday you were here, this patient, this bed was full. There was a person who was there. This morning you've come back to rounds. You know what? This patient's no longer. How does this affect you? Questions to ask. Always use it to teach the human dimensions of patient care. I understand. It looks like the conversation of the family has affected you. What do you think the family is going through? Would you like to talk to their children and come back to me? We spend so much time teaching things that which will become outmoded or they will forget over time. We need to start teaching them on how to create those experiences that will make them better doctors. So, communication, responsiveness, values are probably more important. These are how the logbook entries you can do. The same internal medicine history taking is done on this particular date. First attempt was good. He meets the expectations. It's complete. Put your signature. Foot examination was done. It was below expectations. A repeat was ordered, not a remedial. Very, very simple stuff. You don't need to do fancy stuff. Let me close with some caveats. One, students are part of the team. Again, they have responsibilities, they have a role, they have a respect, they need to be respected, they need to have opportunities. Whatever be the fancy diagnosis you make, if the patient if there is an admission that is important for the progress of the patient, give that patient to the student. Very, very important that you know that these are the competencies that have to be met and not confuse the student with things above his level. Sometimes events unfold. Use the opportunity. A patient can get sick, they can deteriorate, they can have a blood transfusion, but they can also have death, distress, emotions, anger. Each of this can be looked at. I've talked about observation. Dress well, show respect, keep a distance when you talk to people, ask permission when you touch a patient, right? Talk to your colleagues respectfully, respect the nurse, because they are sponges. Lastly, and most importantly, just because you're a great teacher, don't forget that your first task is to be a doctor. If a patient does not want to see a student, respect it. Just because your hospital provides treatment free, the patient is not obliged to be seen by a student. Very important. Without consent, with lack of privacy, don't do this. Set the expectations. Make sure patients are important. Follow your institution's policy. Don't get your career in trouble. Whatever is important for the institution, do it. Always introduce the patient to the student. Always introduce him as a member of your team. I would love this when Dr. Shekharan would always introduce me as, my colleague. It would it would give me goosebumps to think that the man who described septic shock would call me his colleague. Right? He would not even use junior colleague. He would say colleague. That shows what a great doctor he is. You're not threatened by your juniors. You're comfortable in their presence. And he would always ask, Krishna, what do you think we should do this? That's wonderful. Why don't we do that? That's modeling. I still remember him carrying his stick after this thing and telling me, we said that we don't have an interesting patient to present today, he said. And I still say this, and I've said this to so many people. There's no such thing as an uninteresting patient, just an uninterested doctor. Isn't it? Do not forget they are there to provide labor. That's very important to learn as well. Do not overburden students. Give them two patients max. Even if you give them one patient to follow, that's enough. Learning in this program is on the job. So you say, can I observe you to show me how you check for reflexes? That's one assessment. Teach this patient how to give a drug. One assessment. Arrange for a follow-up for this patient. Talk to the nurse about how to care for this wound. You don't need to do. It doesn't have to be a kacheri. It can be a tukda. Address the human dimensions whenever you can. Remember, that's the most important thing we can teach. Right? If they're not certified in a particular procedure, don't allow them to do it on the patient. Very important. That's where the Skills Lab Connect comes. Make sure that if they have to go to class, they go to class. If they have to leave at 6 o'clock, don't tell them this is an interesting patient I want you to see and take care of it. And please don't ask your patients to buy food for you. Do not ask patients to reschedule classes for patient-related work. In the event of a doubt, always follow the hospital student regulation. Governance, reports to the curriculum committee. I won't spend time on this. So with this, I think I may have exceeded my time a little. I don't know with that. Thank you so very much. If the chair permits, we will answer some questions also. And then I will move to the student section. Thank you so much. It's really been wonderful. Thank you.
Those who are online can ask the questions on the chat, or we can unmute them. You can raise your hands.
The chat, lots of
Yes.
questions. You want me to just go through them? Or
Yes,
you-
sir.
Okay, thank you. So let's do the chat and the Q&A. And people from here also, right? Quickly. On the Q&A box, okay, anonymous attendee has asked, learner doctor programs implemented in clinical departments of ophthalmology, ENT, psychiatry, etc. To where no admission happens. At this point of time, you can provide them the experience, but I don't think there should be a formal program that is documented. So at this point of time, I think the NMC is looking at medicine, surgery, OBGYN, orthopedics, and pediatrics. So I think that is the answer to that one. In the chat box, most of the rounds are done by clinicians during 9 to 12 or 2 to 3 in the evening when student will get the opportunity to join the team. So you need to make sure that they have 2 days in a week, which is the post-admission rounds, and one other day where you cut down your didactic clinical teaching, which really doesn't matter, and make sure that they're part of the rounds. You can teach on the rounds. So this is one bit. Not in all clinical postings. We need to be very clear that the mandate is for medicine, surgery, OBGYN, pediatrics, and all. Since we had this experience only in 3rd year in gynae labor room posting, we learned a lot accompanying, blah, blah, blah. So be very careful. A lot of times accompanying house surgeons is great, but house surgeons actually pass information from generation to generation of bad clinical moves. I learned from a house surgeon, he learned from his, he learned from his. I think the supervising physician needs to get it right. So burden of sample collection, not cut job. They should be able to do a phlebotomy in that particular patient, but not in every patient in the ward. Correct? Okay, so that's the most important. Very appreciate your passion. Thank you. Taking students as colleagues is amazing. Also proves seniors are not insecure. Absolutely. Right. So we need lots of manpower for everything. But you know what? The smart clinician knows how to innovate with his or her time, right? Don't eat more than what you can chew. You don't have to achieve everything in one go. You can make small changes, sustain it, teach it to the rest of the team. The second thing is, many of us teachers believe that the world revolves on our shoulders and our heads. No, I am very happy to ask if my senior nurse can teach a student how to take a CVG, how to take a blood pressure. I learned all my critical care nursing, not from Thomas Liao, who was my attending, and I can tell you an insufferable jerk, but from Ronalda, Christina, Maya, and all the wonderful nurses in the critical care team who taught me every bit of critical care. Right? So use the rest of the team. Why should an echo technician not teach you echocardiography? We need to leave our specialty hats out. Patient permission, absolutely. I don't touch my wife without her permission. I'm sorry to say this in an open meeting, but you need permission to touch anyone. Even if you think that they're your own, that's respect. When patients know you respect them, they respect you. Any other questions, comments?
I think Dr. Seshadri has answered most of the doubts. I mean, there's a novel by Dr. A.J. Cronin, The Year of the Intern, in which the intern learns a lot from nurses and all his, it's a good reading. Anyone?
Yeah, I think I would just like to make one point. That's a very important point. Because available around us, and we don't make use of it. Even, for example, junior residents, as per MCI regulations, they are teachers. They are getting 3 years teaching experience, but we don't make use of them as teachers. Senior residents, they are teachers, but we don't make use of them as teachers. And when I was in CMC many years ago, we used to give all the mothers a well-being kit, which included a napkin and a soap for hand wash, etc., etc. And many of the times, mothers didn't know how to tie that nappy. So we involved our nurses to come and teach the mothers and ask our house doctors to stand there and see how the things are being done, because it's their job. They can do it much better than what I would have taught the mothers.
So you can just co-sign it, right? Once, if you're the supervising physician and the nurse has taught the patient how to do this, and the student has demonstrated it, you just co-sign it as someone who has approved it, and that's all it is. Right? Thank you. Thank you again. It's wonderful. Thank you.
Thank you very much, sir, for the wonderful presentation. And it was very nice to have so many real life examples from you as student, as teacher, as experienced doctor, and relating them with the student doctor for better training and for better understanding of the students. Thank you very much, sir. Now we proceed for the next session. Our next session is on integration in practice. The definition of competency itself is an integration of knowledge, skill, attitude, and communication skill for patient care. In addition, many other types of integration, particularly among subjects, are required for success of competency-based curriculum. Dr. P.V. Vijay Raghavan, who is the Vice Chancellor of Shri Ramchandra Institute of Higher Education and Research, Chennai, who has done a lot of work in designing the integration module, will enlighten us in how to achieve integration in competency-based medical education. And the chairpersons for this session are Dr. Rana Ranjit Singh and Dr. Sanjay Bedi.
I am happy to participate online in this annual conference of Health Profession Education 2021. The subject that I'm going to be speaking over the next 40 minutes or so is on integration in practice. We all know that this principle of integration was sort of introduced by the erstwhile Medical Council of India way back in 1997. So if you see the medical regulation book of 1997, you would find that under each of the subject category, a column would come at the end on integration. And they were actually meaning how you could integrate clinical sciences with basic sciences. We were asked to even ask questions with clinical relevance in the basic subjects, even as early as 1997. So the objectives of this particular session, how I intend to take, is that we will see how integration can be used as a tool for curricular development. That is the prime principle with which a lot of faculty members are struggling right now. So I will give some sort of input towards that. What are the evidences of integration being practiced in various institutions? We will also discuss a bit about the terminologies that are being used in terms of alignment, in terms of sharing, nesting, and things like that. Ultimately, how integration is used in curricular design, we will have a small discussion on that. Feel free to sort of raise your hand in case there is some sort of a question that you want to raise, or you can even do it at the very end. I'll give at least 10-15 minutes for discussion. And we also need to understand, and this I did by an exercise of getting a questionnaire answered by faculty members from various medical colleges that are attached to our nodal center. And we were able to get some sort of an idea how integration is actually being practiced on the ground level. And ultimately, we'll have to see how we can bridge this gap in terms of this principle of medical education. We all know that the goal of medical education is to create medical graduates who have to show the competence in knowledge, skills, attitudes, values, and responsiveness to function as a general practitioner, not as a specialist, but as a general practitioner or a primary care physician who is locally responsive and globally relevant. And integration.
Can you go full screen?
Can I go? Yeah, 1 minute.
Full screen.
One minute. Is it okay?
Yes, sir.
Yeah. So integration is actually used as a teaching learning method to reach that goal. And this is exactly what we are working at. Harden was about the educationist who gave some sort of a basic understanding of this principle. And he described this as the organization of teaching matter to interrelate or unify subjects frequently taught in separate academic courses or departments. See, we teach anatomy differently, physiology, even there is some redundancy or even repetition, we tend to do it under different type of courses, and how we can sort of unite this. We also should know that it was Harden who defined the various stages or the various steps by which integration can be moved to higher levels. Most of the medical colleges in India till at least 2019 were practicing the principle of isolation, that is teaching subjects all by themselves in separate compartments. When you go to the next levels like awareness, harmonization, I will define that with some pictures and explain. And right now, through the CBME curriculum that has been introduced, almost most colleges have reached the stage of temporal coordination, where they are able to sequence and they are able to also put subjects under some sort of an alignment. Even though the teachers were from different specialties, we were able to do up to that level. But ultimately, we should at least reach the stage of correlation, which happens through the principle of problem-based learning, leave alone that there are some institutions in the West which have gone on to complementary, multidisciplinary, or even transdisciplinary type of integration. What is the purpose? Why exactly should we do this? Is it essential at all? And I thought I will just give some thought to this particular thinking. An integrated approach in medical education, it captures students' attention and creates more excitement, a sort of inquisitiveness in him in learning. It prevents repetition of subjects. It enhances reinforcement of important areas or topics and improves retention of learning. This is not my statement. This is from the article by Coyens et al. And here I must also recognize the paper that Dinesh Badial and Tejinder Singh brought out in 2015. Long pending demand of students that basic and clinical sciences should be integrated can be achieved by using this approach. The purpose again was elaborated. Students trained with such an integrated curriculum make more accurate diagnosis than students trained in a conventional curriculum. Again, a paper that sort of brought out this is by Badial, Musharraf Hussain and co. So this actually promotes a holistic approach to patients, and at the end of the day, medical education is not about naming syndromes, the various causes and things like that. The whole idea of medical education is that at the end of the day, he should be able to see a patient, take his history, make a diagnosis and treat him. For that, quite a lot of thought process has to go on in the mind of the doctor before he can do this. So that type of a holistic approach we were missing in the past, and now some attempts have been made for students to learn slightly differently, although to some limited extent. It also promotes interdepartmental collaboration and helps in rationalization of teaching resources. If you ask to any medical college, the first complaint that any HOD will always do is that the number of staff members are not sufficient. The MCI has not given sufficient number of members to take all these elements into account. So we will have some discussion if you feel like about this, but I think if you follow the principle of integration through an organ system based approach, which we have been following at Sri Ramachandra since 2006 onwards, the number of faculty members can definitely be reduced. There are two types of integration that we should be familiar with. Most of you must be already aware. The horizontal integration is sort of trying to bring subjects in the same phase, like anatomy, physiology, biochemistry, and community medicine together under the principle of horizontal integration. The same thing when it happens between subjects which are taught in different phases, then it becomes vertical integration as is shown in the figure. So ultimately now there is this concept of spiral integration where, you know, like a funnel, you have different sort of subjects being taught in different phases. We should somehow connect these in order to ultimately gain the cognitive, the skill element, as well as the affective domain in an individual student based on the various inputs that he has got through the various phases of his MBBS curriculum. Now, this is what I was telling, the progression of integration, when you look at, we are somewhere towards temporal coordination. These are the various subjects shown in different colors, right? Early on, it used to be completely isolated in the teaching. So much so, the anatomy department does not know what the physiology department does, or the physiology does not know what happens in pathology. But today, because of the slight awareness and some sort of a harmonization amongst the subjects, we are able to sort of collect all these under alignment topics, which are brought under the same time frame. Some sort of sequencing, some sort of a synchronization has already started happening because of using this principle. Nesting is a principle, I'll explain in another slide, where one part or one theme of another subject, which is relevant to this particular subject, will come in the same module. So that is nesting, and we also have the principle of sharing. The Vision 2015 document that was released by the Ministry of Health does also consider integrated teaching as a principle, and they allowed for some sort of integration to happen right from the first phase. During the preclinical phase, the expectancy was that 80% will be basic subjects, and there will be at least a 20% integration of the clinical subjects during that time itself. In the paraclinical phase, the percentage of contribution used to be 60% for the paraclinical and 40% for the clinical sciences. When you come to the third clinical phase, part 1 and part 2, the basic sciences will fade into a 20% contribution, and 80% will be purely clinical. But one must understand, in principle, this is all very nice to put it in charts and speak in lectures. But in reality, to actually find out the hours that are given to each subject under the present pretext of the NMC regulations, it is sometimes very difficult to exactly put it under various percentages. The extract from the Graduate Medical Education Regulation 2019, I just brought this for the information of all the participants. The salient feature of the revision of the medical curriculum, why did we at all think about revising this, is that the emphasis on learning to a great extent from just knowledge acquisition and just rote memorization, we are moving more and more towards competency-based, integrated, and student-centered. And this is from feedbacks from several students that they enjoy when they are given connectivity between subjects. And acquisition of skills is the prime importance. And we also give sufficient importance to ethical and humanistic values. Of course, the didactic lecturing, even in the 1997 regulation, had been reduced to about a third of the whole curriculum, and which is being continued even now. There should be greater emphasis laid on hands-on training, participation in symposia, seminars, small group discussion, and problem-based learning. And students must be encouraged to take active part in and shared responsibility for their learning. Again, the GMER goes on to elaborate further that integration must be horizontal as well as vertical, which I defined earlier. As far as possible, it is desirable that teaching or learning occurs in each phase through study of, there are two strategies that one can develop in order to build up an integrated curriculum. At Sri Ramachandra, we are following the organ systems block. And I will also tell you that in spite of doing this way, our students have aligned themselves very well to the final university examination without any difficulty and performing fairly well. It is also possible to introduce this through disease blocks. And as a chairman of the task force to monitor this, I find most colleges, almost 80% of the colleges, have chosen the disease block as the module, and they have been introducing quite a lot of diseases under the integrated pattern of learning. Subject-specific competencies with appropriate alignment and integration are already available in the new competency-based UG curricular document. 3 volumes, most of you must be familiar with, and that can be used. However, care must be taken to ensure achievement of phase-based objectives are given primacy. We should not lose track in our milieu to just introduce a new teaching learning method. We should not forget some of the important components of the curriculum being missed out because of not being able to align itself towards integration. And topics that cannot be aligned and integrated must be provided adequate time in the curriculum, and it should run as parallel sessions. Assessment, of course, remains subject-wise, and we have no choice because the MCI has not introduced an integrated assessment to be brought in. So we have to go by the subject-wise assessment, but in the formative stage, attempts should be made to ensure phase-appropriate correlates in the form of integrated OSPE, or even case resolution assessment, so that the learner internalizes what he learns through the principle of integration. Now, the regulations have recommended, and all these have come in the booklet that itself has been released on the MCI website. Almost all the colleges have to have alignment principle or temporal coordination of 80% of the curriculum that they want to teach during the same time frame. And this, if you ask me, on the ground in practice, is a difficult thing to achieve, but a lot of colleges are making extraordinary efforts to do this. To my mind, probably the nodal centers and the regional centers have grasped this very well, but many of the other colleges probably will take some time to follow suit. It allows similar topics in different subjects to be learned separately, but during the same time frame. So anatomy, physiology, all these things will teach those with their own teachers, but it will be during the same week or during the same day. So regulations also recommend integration only to the extent of 20%. Now that is what is the present status, how much it is allowed. Here, two important principles are usually being used by most institutions, and they have understood this very clearly. This is the principle of sharing, where two disciplines may agree to plan and jointly implement a teaching program. Say, for example, bilirubin metabolism. It sort of embraces itself very well, both for physiology and biochemistry, and this can be done through a single lesson plan, and teachers could be two different teachers, or it could be even one single teacher. Now, nesting is the principle. As much as possible, correlates from other phases must also be introduced while discussing a topic in a given subject. Now, to make it more easy for you to understand, while teaching the structure of a heart in anatomy, it may be worthwhile to simultaneously teach the function of the heart as a pump, and as it happens in pathology, its loss of function in cardiac failure. So these are some of the principles that many colleges have understood and they have picked up. Again, in the 20% concept, you could introduce this correlation principle where you choose a particular disease, say diabetes, hypertension, or anemia, whatever may be the topic. The emphasis on discipline or subjects with subject-based courses taking most of the curricular time. Within this framework, you can introduce a case resolution session where all the concepts taught in all other areas with the issues identified can be sort of taught together in a linker session. And for this, the moderator could be a clinical person, and this could happen even in the first and second phase itself of the MBBS. So these are the various principles right now that are being utilized by the present JMER for getting the principle of integration. How exactly should we integrate? Now, this is a slide that if you understand this, I think the whole integration becomes easy. Most of you must have seen this particular slide because this is what we concentrated and did this even during the CISP. And first you have to decide, you have to choose the competency that needs to be achieved by the student, whether it can be taught in only one subject or whether it can be taught in several subjects together. If the answer is no, then ensure that these are allotted specific time and are running parallel to the aligned curriculum. That is the first thing that you have to clearly understand, whether the competency can be taught together by many subjects or cannot be. If it is not, then this is the strategy that you have to adapt. But if it can be taught, say, just for example, say informed consent as a concept for the student to learn, there is no need to carry this into general surgery separately, ENT separately, ophthalmology separately, or orthopedics separately. They all can come under one competency development. And since the answer is yes, you can choose one strategy for alignment of competency, and that is either as an organ system block or as disease block. Just to again give you an example, organ system blocks can be cardiovascular block, respiratory block, genitourinary block, musculoskeletal block, the neuromuscular block, things like that you can define. And you can bring the teachers of all these subjects to come together to define the various competencies that will come under that, and under that develop the sub-competencies and objectives that needs to be developed. So having listed the competencies in that particular aligned and integrated topic under the respective subjects in each phase, and for each phase, review the competencies of all the subjects and reduce redundancy. Don't do the competency again and again, over and again. So that can, sort of gain time for you in order to sort of cover the whole syllabus. Review competencies from other phases and mark with which of these needs reinforcement or introduction in the current phase. So there may be sometimes some physiological concept that needs to be brought in even as you are teaching some medicine lecture or a medicine topic. Now that is something which you also have to look at even as you plan. After doing this, the next step should be create lesson plans or learning sessions. Now that will be concentrating mainly on the sub-competencies and objectives for the major competency that you want the student to develop. And this also can be united, and for the student to understand the whole process, create a linker or an integrated session where learners can integrate various concepts that they've learned and ultimately solve the puzzle at the end of the day. So allocate time for the students to do a lot of self-directed learning, because all these objectives that you mentioned, it can be done as flipped classrooms where they can be given the objectives well in advance, the students come prepared, and you just test whether the objectives have been achieved or not. Of course, the whole backbone of an integrated curriculum depends on a very committed formative assessment. And this should be based on almost session-wise assessment and also weekly assessments and things like that. Of course, because you have included some non-aligned subjects as well, you may have to include some component of assessment for the non-aligned portion as well. In case you are running parallel sessions, in the timetable itself, try to include both integrated sessions and non-aligned subjects. Now, these all we have been able to sort of help many colleges to have it in separate color codes so that it becomes easy both for the student and the teacher to follow some of these principles. Ensure integrity of total hours recommended. Now, this is where, teachers will keep objecting, and even the NMC has got very great number of hours to be devoted for each subject. So keep that always at the back of your mind, how you can maintain that with all these principles in place. So far, what has been done? Now, this is an interesting study that we were able to undertake. The CISP was developed by the Medical Council, and this has gone on to almost all the institutions. And this is supporting the curricular changes that have been proposed, including the session on alignment and integration. And we also have helped out institutions in terms of how the curricular governance can happen by creation of AIT committees for each of the aligned and integrated topic. Faculty guides have been created, and timetables incorporating AIT have also been produced by many colleges. In actual practice, we actually conducted an online survey as a formative evaluation of the alignment integration. 88 participants, this whole thing happened in about 15 days time. So we were able to get the inputs from about 88 participants, faculty members from the various colleges that are attached to our nodal center. Now, the feedback, how we received was through this question, which was addressed. Alignment integration is a very important component of the CBME curriculum, and we wish to undertake this survey, and we requested for the permission, which when they participated, it was an automatic implied consent, and the data gathered will be analyzed and used as a formative evaluation. What were the questions that we asked? optional. Name, we didn't want every faculty member to bring it out. Some of them did write their names, otherwise it was left optional. College from which they come, phase of instruction, which phase, first, second, or third, name of the department, position in the curricular governance team, what strategy adopted for integration, what topics for year 1 for AIT were selected, and what topics for the year 2. The average duration was also asked. Who did the curricular planning and implementation for that particular block? Was AIT incorporated into the timetable? And 3 components highlights were asked from each one of them. And what are the top 3 challenges in implementation? And these slides that I'm going to follow will give you some sort of an impact on what has happened by practicing integration. Now, the phase-wise, we found that majority of the responses came from the preclinical faculty, 41.4%, and the clinical faculty, as expected, because even the students have not come into the third phase as yet, was about 20%. As per their position in the curricular governance, we found that almost everybody contributed, but a majority of them was the MEU member or a curriculum committee member. So these were the various people who had participated in this contribution towards integration. The strategy adopted, this is very interesting to know that while it is probably a little easier to do on disease-based, majority, about 55.8% of them did it through an organ system-based teaching learning. Others was about 8.1%, which was, if you ask in any conference, what is the integrative practice that you are doing? Almost every teacher will have an answer. They would be following some principle definitely. Many times just walking across to another department, getting another teacher involved into the session which he is doing, are some of the simple small things that some of the institutions did follow. What topics? Now, majority of them have chosen disease-wise, jaundice, hypertension, anemia, diabetes, hypertension, thyroid. But the organ system-wise, a lot of institutions have adapted to the cardiovascular and the nervous system block. Now, these are the 2 that have been used. Was the aligned and integrated topic session plan integrated to the timetable? This is very, very heartening to know that because of the insistence of creating timetable well before in advance, 95% of the colleges have been able to integrate the integrated topics into the regular timetable. Who did the curricular planning and implementation? Now, answers were variable. Curriculum committee, majority of times, head of departments, faculty members. I think one institution, it was mentioned dean. It's very rarely that one single person can do all these activities, but I just thought I'll include that response as well. Medical education unit, AIT committee in many organizations, and MEU members of respective faculties. What were the challenges? It's very interesting to know that once the Ministry of Health and the Medical Council announced the competency-based curriculum in August 2019, we hardly had 6 months of regular time. From March 2020, we have been affected by a big pandemic. So a lot of institutions did struggle in bringing out quite a lot of concepts on the ground. There was a problem of availability of clinicians. Many of them were involved actually in the care of patients of COVID. So this is another huge challenge. There was faculty deficiency in some of the colleges which are working with our nodal center. This is a very important challenge and people are all struggling. And I think the future should be to have more and more focused workshops only on integrated assessment, because the principles there are slightly different and we'll have to concentrate on that. And also creation of linker. A lot of people have just borrowed, cut, copy, paste from some of the nodal centers on some of these principles. But there is a lot more work that can be done individually by individual faculty towards all this. There has been a constraint in teaching hours, and interdepartmental relationship has been a problem, a challenge in many colleges. Of course, teaching methods There are plenty of opportunities to introduce very, very active methods. In our institution, we are connected to our own LMS system. And so that allows for quite a lot of integration, quite a lot of innovation, and also introducing some assignments which the student is able to narrate and get back to the teachers. Online teaching, of course, has been a challenge, but today I think most of the faculty are fairly well trained to do this. And this I already alluded to. The suggestions for improvement, of course, is that the faculty development program for CBME has to continue. Even if it is not happening from the central MCI level, it should continue at the departmental level as well as at the MEU level. And this will greatly facilitate almost every principle being understood properly and being done. And curricular governance for monitoring and implementation. Now, since I'm leading this particular group since almost last 1 year or so, I find that whatever Google Forms you may develop, whatever method you may develop in order to get the feedback from the various colleges, ultimately, these are things which have to be internalized, and people will have to follow with their own curriculum committees and things like that in terms of monitoring and implementation. I am trying to give even the suggestion to the NMC, where there should be some sort of curriculum committee member who should be made in charge to sort of give a report on how exactly many of these principles are being followed. This centralized system is okay. We do get quite a lot of proofs on how exactly people have done, but ultimately we may not get the real truth on the ground. So integration in actual practice, which is the topic with which I started talking, we have to, at the end of the day, get some measurable outcomes. Have we defined what are the measurable outcomes? How exactly you are going to judge whether the principle of integration is working or not? It is too early, because once we apply these principles, the outcome has to be measured on the student who has undergone that particular methodology. Curricular implementation outcomes. Now, this is probably possible a little earlier, because this has to just see on the timetable how you have planned your sessions, whether the sessions happened on the ground in the same way, how much it worked all right. Ultimately, the student outcomes is what will tell us what we have done is right or wrong. And the real effect of all these changes which have been introduced in 2019, probably we will be able to see only around 2025 or 2030. So outcome measurement actually needs to be aligned with integrated assessment at the formative stage. Any amount of stress only at the summative stage may not yield you results. Similarly, based on the performance of the individual in a university examination and giving out percentages as success of your teaching learning method, again, is likely to be questionable. Again, I'm open to discussion. That seems to be the easiest way today to assess a programmatic evaluation. But I think there should be some other mechanisms that we should be able to follow. Curriculum, probably the performance in NEXT, which the Government of India is going to introduce as an alternative to NEET PG, might be able to give us, although it is again a theoretical test, and how much it will be able to bring out the skill element of an individual is questionable. Curriculum implementation outcomes should be through appropriate questionnaire development and a response from both faculty and students. Right now, most of my responses have been from faculty, but we should also be able to get some sort of input from the students. Student outcome through final university examination results may not be ideal. I talked about this already. And student performance through clinical competency tests. Now, this is most important. It is very nice to talk of CBME, but if you have not defined the certifiable skills that every student must have achieved in the first phase, second phase, third phase, or even subject-wise, I think this whole clinical competency-based education may not yield the results that it should. So these are some of the benchmarks that we should look at. So I just conclude by saying that integration as a method and principle should be used towards competency development in CBME, and not merely as a principle where there is definitely going to be some conflict of interest among various specialists, but how we are going to overcome that is what we have to look at. Some form of integration has been used by all faculties since 1997. So it is not something very new, unlike the student doctor method or something like that, where people have not been used at all to such a time. They are used, actually, even that they are used in the postgraduate education. They have to bring those type of principles into the undergraduate level as well. Present GMER document, it actually provides for structured use of vertical and horizontal integration through either the organ system block or disease-placed blocks. So this is something which each of the curriculum committee, all the educators in a particular institution should think and use it appropriately. Of course, these are early days and things can only improve from here because the principles have been laid down. The foundation has been laid down so very clearly that we could take pride that this can only improve from here. And I am of the opinion that we should have more training towards integrated assessment modules, and we should embrace more and more of integrated assessment in the formative stage. And once you do this, certifying a person in competencies and in certifiable skills becomes easier. And then that is the way forward as I see. Thank you very much for your attention. I am open to any questions.
Those listening online can write their questions in the chat box. Dr. Kiran Goswami is asking, there were clashes when individual treatment was different from national programs like Malaria Week in second year. Sir, can you see the chat yourself?
Can I do that? I'll do that.
Yes, yes, you can yourself also see.
Yeah, integration has reduced redundancy in few subjects like Malaria Week in second year. Each subject taught about malaria, parasite and drugs, and students were aware about all. Myself being faculty in PSM just discuss these and concentrate on prevention concept. Students are happy and learning the concept. I don't think it's a question, it's more of a comment that they are happy with the progress of using.
Yes. Has any study done to assess students' perspectives? How is the assessment done after AIT?
Absolutely. This is a wonderful question. So far, we have not really taken appropriate student feedback. General student feedback for many NAC institutions, which are accredited by NAC, is taken on curriculum, but specific questions on alignment and integration have to be asked before you can actually get some answer. The assessment, as you rightly asked, AIT, whatever subject you have taken, should definitely have developed a case scenario which the students should be able to come to small group discussion areas where they will be asked questions on that and they are marked. That is one. We can also create some integrated OSCE and OSPE, and those also can be done. As I told you, this is the weak area. This is the weak area. To my mind, I think many faculty members are not that well trained towards integrated assessment. This is a huge effort that Sri Ramachandra has done. We can share some of the integrated questions that we have actually developed for the students to attempt.
Yes. Any questions from the house here?
Sir, it would be very on the NCHP wall. Would sir be able to share the questions?
Dr. Sucheta is saying, can you share the questions on NCHP wall on the website of the NCH or the NCHP?
Yeah, definitely. I'll share the questionnaire. I'll share the question.
Yes, sir. Yes, sir. On WhatsApp.
That would help us and
Okay.
give us a guidance.
Yeah, in fact, these are very early days, so I'm not perfect with that, but I'll still share it, and you can add. You can give your comments on some other questions that can be added there.
Yes, sir.
Sure.
So you said that you have implemented organ-specific curriculum.
Yes.
So how did you go about it? I mean, organ-specific is there in many countries, but at present, the one which has been provided, it's slightly still subject-based.
Absolutely. I'll give you the story of how it developed in Ramachandra. Actually, we started this activity as a disease-based module only. We chose about 10 diseases and started working in 2003. Almost about 150 faculty members from different specialties views in group meetings at varying points in time was able to develop big box files of the various competencies and objectives as per subject, disease-based. Now, having done that, what happened was when we wanted to teach this in that fashion, there was a lot of conflict of interest. People said why anatomists should go and teach physiology. I mean, the plan was like that. So that forced us not to be able to implement. And that is where Harvard came in to help us, Harvard Medical School, because of our collaboration. What had happened was they said, see, if you go into the subject details, there'll be a lot of conflict. Each one will say my specialty, why somebody else should take and things like that. Why don't you do the pro-dev? That is the common things like ethical issues, informed consent, things like, breaking news or breaking bad news, as they call, truth telling, such type of topics. If you develop some sort of a case-based teaching, I think all will come together and it will be able to unify the entire faculty. It is a wonderful advice. I think all institutions should try out some things like that. Now that ADCOM module has been introduced by MCI in a very big way, I think we should not be leaving this ADCOM entirely to one department and things like that. We should try and allow all the departments to come together to take these type of sessions. So we did practice that for almost 1.5 years, taking those topics without, and a lot of clinicians also were very interested and they cooperated. Now, having done this from 2007 onwards, we thought that the better strategy would be to make it as cardiovascular block, respiratory block, and the anchoring case for each was chosen. Like for cardiovascular block, we chose angina pectoris patient as a anchoring module. And all the elements, issues that the student has to learn in terms of anatomy, physiology, everything was brought under that. So at that given point in time, when they go for dissection of the chest, that is the same time they used to have the physiology of the cardiac function and things like that. So we were able to sequence and align them in that fashion. And we also had formative assessments in the form of integrated OSCE and things like that introduced. However, what I need to really carefully tell everyone is the summative assessment was as per subject based, and they did have some clinical correlation and things like that. And a lot of external examiners did come and tell us that your students are extremely good in the clinical area, they are answering, but sometimes some of the basics like identifying a tubercle on the microscope, those were areas that they were probably falling short. So probably we are all learning that there should be equal importance given to basic science as well as clinical science. So that was the next stage. We had developed almost 7 blocks for the first phase. And there will be some portions which will not form under the blocks, which are still important. No, those are the non-aligned things that we left behind. So ultimately, our students adapted themselves so well that there was no difference in their performance when it came to final exams. That was a very big risk that we were taking, but I think it works. Because of our practical experience, it works. People, the individual's cognitive domain works out on the pattern, how to answer these type of things very well. So that is how we went in for the organ system block. Now I am finding actually, when I got in this survey, 55% of people following this, that means probably they are understanding integration much better. The problem is that if you want to have the final exam on an organ system block, you must have the anatomist, the physiologist, the pathologist, everybody coming together for an exam. Now that is where we are struggling, how we are going to do that. I think some sort of a solution will come. We'll have to follow some of the Western universities which follow this integrated curriculum and then take it from there.
Thank you, sir. There is a question that whether NMC allows us to change to organ system. I mean, there's a clarification.
No, the excellent question again. So far, they have given it as option, but preferable for people who have not understood this and worked on long time is to go for the disease module, because 20%, Alignment, you can do it on an organ system base. There is no problem. You don't bring in integration. You allow anatomy, physiology, everything of the cardiovascular system, respiratory system together. That is quite possible. That MCI is allowing, no problem. But you cannot do a integrated. That is, you cannot teach it as problem, like, case of bronchial asthma. In the Harvard School, they had only about 10 diseases which they combined in this integration. And that's all that the student had to learn in MBBS. But that much, I don't think the MCI is permitting right now.
Okay. Thank you. Sorry. Yes, sir. Yes.
Yeah, we have been struggling with this issue of integration right from 80s. I remember we had our first training programs in medical education in mid 80s, and we are introduced to problem-based learning, and then we had our FAMER fellowship. And
so you can speak here.
Methods. Can I come there?
Yes, sir.
Yes, sir. Actually, from here the
Okay.
sound can go back. This is, I
Okay.
think, not working.
Okay. I'm Dr. Daljit Singh. I'm the Vice Chancellor of this university. And my background of medical education and the technologies which are associated was the basic reason why I came to this position eventually. Right from the 80s, we have been struggling with this issue of integration. And we had exposure to many different methods like problem-based learning and so on. And we saw some very nice models of education which had integration, like as we have been describing the disease-wise integration, the system-wise integration. And there were some actual practical examples also. I think there's a university in Egypt also which follows this. There are many other universities in the world. What has happened now is that, as I agree, until you change the assessment system, the examination system, the results are never going to be as good as we want, because the student is basically interested in his result, in his passing the examination. And so whatever we may do, we have to find a method of modifying our examination system. There are constraints, there are difficulties, I know, especially because at present, everything is compartmentalized. There's a department of anatomy, there's a department of medicine and so on. And the teachers of those compartments are very vigorously and almost ferociously defensive about their own department, which is actually counterproductive, because that's not the aim. The aim is to produce a doctor who can deal with patients, and the patient doesn't come with a label of medicine, surgery, and so on. So I think there has to be a total overhaul. This competence-based medical education modules now, which we are starting and which we have introduced, is a very good step. But actually, you need a revolution, and that revolution will start from changing our evaluation system. Until we can modify that, all those little tinkerings and the little things we can do will remain as innovations and will not really do the trick. So I firmly believe that it is not so difficult to get different departments together for evaluation, because in fact, if you see, let's say if I'm an anatomist and I am involved in the teaching of students from first year till final year, I should be happy about it. Similarly, a person in medicine should be happy if he is also able to interact and do something in first year or second year. So it's not a challenge. It is not against any particular department. We have to get out of this mindset of being in one particular discipline and in a very small nutshell. So I think this integration basically means this, getting out of compartments. So I think we should re-emphasize to the NMC that this is a good beginning, but it will take us forward only if we can allow universities to modify their examination pattern, or the NMC itself should modify its examination pattern to make sure that the integration is there right through, and not as a first prof, second prof, part one, part two. I mean, that is, I would say, historic now. We should get out of that mindset of having those kind of subject-wise divisions and get into the integrated mode, not just see, because those four cornerstones of education, the objectives, the methods, the material, and the assessment, they all have to be aligned. And if our assessment, if our objectives are clear, then we have to modify our methods and we have to modify our assessment. So I feel that we are trying, but it's not good enough. And it is only at certain places, like you are doing a good job at your place. I don't think it has happened in most other places. You need a revolution, and that is the only thing which will turn our medical education to the goal which we want. So this is what I feel I have been feeling over the last 30, 40 years in which I have been involved with medical education. Thank you.
Thank you very much, sir, for that extraordinary. You actually stole most of the words what I have in my mind and spoke. That is exactly the problem, sir. Even in our own expert group, sometimes when I passionately speak about this, I do find people will not be accepting this in full toto, the principle of integration. But I think we have made a good beginning. Right now, as you rightly said, the assessment, the present system of university examination, even in the new document, allows for OSCEs and OSPEs to be included in several subjects. Now, that is where instead of going only subject-wise, if you are able to create some integrated pattern of OSCEs and OSPEs, it might help. As you rightly said, this is work in progress. To my mind, it's a work which has started, so it will take time. And there has to be, as you rightly said also, that the mindset of the faculty needs to change. Nobody needs to worry that their job will go off. As you rightly said, they need not be teachers only for the first year. They can teach for the entire batch till the entire MBBS is completed. So well said, sir. Thank you very much. Nice meeting you. So
Yes.
the other.
Thank you, Daljit, sir. There are a few questions, but more questions, but they are not related, and we are running short of time. I think. Thank you very much, sir. It was an excellent lecture.
I just wanted one clarification. One question has asked how Ramachandra has been able to overcome the NMC.
Yes, sir.
There is no need to worry about that, because whatever we have done has been within the purview of the syllabus that the NCI has prescribed. So we have had no problems either through the student forum or from the faculty about practicing these type of methodologies. And as I told you, we have not gone to the transdisciplinary stage. We are still only in the temporary, temporal coordination stage. So somewhere middle. Thank you, sir.
Thank you, sir.
Thank you so much, sir, for this wonderful session. It would have been wonderful to have you here in person, sir, but we understand because of this current situation, pandemic situation, you could not make it. So we extend heartfelt gratitude to you, sir. Thank you so much.
Thank you.
The doctor's ability to make ethical decision-making skills were challenges. They were, even having learned and having been taught, they were unable to manage the challenges of ethical decision-making in the clinical practice. So from this, there was a need for a reform. Of course, in 2001, the UNESCO chair was created for this reform. And over a period of time, much of the studies were done, but a new, modern, horizontal, vertical, integrated bioethics curriculum based on the core curriculum of 15 principles was put together. And there was a need for ethics curriculum to be seamlessly integrated longitudinally into the course. And what was the reform also found that medical and healthcare teaching faculty had to teach ethics. So pre, para, and clinical teaching faculty now were given, had the mandate to take over the teaching of ethics, bioethics in the medical schools. And in order to do this, they needed some training. And as I said, teaching a medical humanity which has less scientific certainty is marginally is different from the medical sciences, which is based on more scientific certainty. So innovative teaching development in teaching bioethics program had to be put together. And for this, what they found was the teaching faculty needed training to use evidence-based innovative teaching methodology. And the evidence showed, and we'll show you some of the pilot studies that actually showed that all faculty, teaching faculty, pre-para and clinical, when given that training, they were able to effectively, efficiently, and efficaciously teach a medical humanity, and in this case, bioethics. So the faculty development program was created, and the 3T integrated bioethics in the health sciences curriculum was put together. Remember that the vertically integrated curriculum was published and accepted at medical teacher for the 40th anniversary of medical teacher. This was in that publication for all of you who read there, who get the medical teacher. Now, the faculty development training came up, and this was developed for undergraduate and postgraduate medical and health science teaching faculty. And this faculty training program focused on skills and didactic means for teaching faculty through the reformed and tested methodology of teaching bioethics. And of course, there was experiential and meaningful teaching was an important part. And the result was learning imparted emotion. The result of this, the developed training to faculty resulted in learning that imparted emotionally, cognitively, and behaviorally. Faculty were are equipped with practical and applicable tools for their teaching and training, bioethics teaching and training. Faculty are exposed to special, fascinating, innovative thought processes for teaching bioethics. And the program offers an added value to the teaching faculty's earlier accumulated teaching experience. This was what was found. Remember, earlier it was being taught by ethicists and moral philosophers. When this reform came in and regular teaching faculty were brought in and trained, we found that this actually added value to their experience, their accumulated teaching experience that many of them already had. And of course, the an important aspect was adapting the methodology of osmosis learning. The wide use of osmosis learning, what is called the art of unconscious learning. The learner, where at this point, the learner stops studying material and starts absorbing them. And it's an analogy for natural, organic, indirect way of learning. Learning through osmosis is a way of learning seamlessly. And of course, learning through osmosis is about listening. And the result of osmosis learning methodology is the absorbing the workshopping of role play, debate, cinema, and street play, or what we call the participatory theater. So this was the methodology, some of the methodologies used, absorbing the workshopping by role play, debate, cinema, and street play. And importantly, the science of knowledge transfer methodology was also brought in and infused. We know that the innovative reformed methodology is based on the science of knowledge transfer, that is, the ability of influencing the limbic system of the brain to underpin neurocognition and knowledge transfer. So stimulation of that was important. And of course, we know that the limbic system is an important part in neurocognition, particularly in ethics, where emotions reside and memory begins. So both these functions are combined and are very important when we want in bringing this neurocognition to start the process of neurocognition. Now, the outcome for the faculty training we could see was modern bioethics knowledge transfer technology. In this modern technology, we use the underpinnings of neurocognition sciences on teaching competencies, emotional intelligence in teaching methodology for medical and health science teaching. A very important component of emotional intelligence is brought in. The use of innovative teaching methodology using role play, acting, debates, art, model games, cinema, and participatory theater are some of the evidence-based innovative teaching methodology. And the use of evaluated case-based teaching methodology in medical and health science education was also included. The ability and the training, the faculty outcome, when we looked at the outcome, they had the ability to identify an ethical issue, apply the principles, ethical or bioethical principles, and use of bioethical deliberation in decision making and resolving ethical dilemmas. Everyone who deals in clinical work will face ethical dilemmas. But how do we make an ethical decision in this situation, in this context, is important. And they found that this faculty training brought on this ability. This curriculum is taught and assessed formatively with summative assessments alongside with every subject of the undergrad training curriculum in medical and health science education program. And that was the vertically integrated into each and every subject. So we can see the needs assessment. Do you think, then the faculty were asked, do you think there's a need for formal training for your healthcare professionals? Again, we saw some results there. What do you think the best method of teaching? Of course, the vertically integrated scored the highest, and of course, online courses, certificate courses, workshop, and so forth in bioethics training. In your opinion, is there a need for cross-cultural relevant bioethics? Yes, of course, it was important. And what do you think is the best evidence-based teaching and learning methodology for bioethics? Case-based learning came out as one of the, of course, we know it's a fully evaluated, as we now have for the faculty development program being fully evaluated. Now, the training and curriculum, the Department of Education designed, piloted, and tested the modern vertically integrated bioethics curriculum that featured in medical teacher 3 years ago or 4 years ago. So the innovative teaching methodology was used, as we have already explained, using of theater, using of role play and tableau and or case-based learning were some of the innovative methods. But there was an additional 18 to 24 weeks, a weekly course on what to teach, developed based on the 15 principles of the Universal Declaration on Bioethics and Human Rights, which of course was adopted by 995 countries on the 19th of October 2005. And I am happy to say at that time the executive that brought this out, India was on the executive of the 33rd General Assembly of the UNESCO, the United Nations Forum. The second phase, so we had the what to teach. The second phase focused on 3 days, which was a face-to-face interactive teaching methodology and assessment. That here was the focus was much on how to teach. And the distance learning was focusing on what to teach, and it was the co-curriculum that was used. And again, you could see the bioethics co-curriculum was the basis on what to teach. And there were 3 domains of innovation. One is the modern vertically integrated curriculum that when integrated into every subject-wise. there was a reformed evidence-based bioethics teaching methodology. And the third is incorporation of bioethics pedagogy into medical education. You'll see the 3-day, we talked of the 3-day face-to-face, or what we have, the how to teach, focused on these. The first day was pretty much on the basic concepts of, history and some of the articles on the bioethical issues. The second day was a lot of focus was on knowledge transfer technology, teaching emotional intelligence, and the other areas of deliberation, ethical deliberation. How do we reach an ethical decision forming, case-based learning, and so forth. And the third day, of course, was integrating ethics vertically integrating it into subject-wise preclinical, paraclinical, and clinical integration. And of course, there is the neurocognition of enhancing teaching competencies and so forth, how to teach in a clinical setting and so forth. So this was the faculty development program. And and here are some of the lectures that were being taken, as just for you to see. We have a role play lectures being taken. Here's role play that the faculty were faculty were taking part in. The Tableau, use of Tableau, again, faculties taking part in this training, using Tableau, particularly in discrimination, stigma, Article 11 of the Universal Declaration. So this was how, and then of course he used what's called the SLICE model, or the structured learning in clinical ethics model was used with the faculty. And here's the faculty taking part in the training using the SLICE model of teaching ethics. So, and then of course the completion ends with a program where they actually have a teaching simulated teaching method where you have a 360 degrees a short program that you actually generate. So this is the completion of a 3T course that brought in teach, train, transfer, and this at this stage it is the transformation. So the 3 T's get you to the 4th T, which is the transformation. So this is there was of course data obtained for post, and this is of course for the what to teach webinar, face-to-face practical sessions for significant increase in participant understanding of all the topics that we evaluated by the paired t-tests. And of course, results suggested that teaching methodology satisfied the objectives of faculty development program in teaching bioethics. Now, we also had a qualitative satisfaction qualitative study, which looked at what the faculty thought. And of course, results were like this: interesting and necessary, need to innovate and be relevant, on a quest to be a role model. Students are captivated by ethics or not, all or none phenomena. Students maintain the spirit of bioethics and ask for related programs. And of course, bioethical discussions with students bring out new perspectives. So this was some of the faculty coming back. Now, when it came to students, the integration into the curriculum, they had the introduction to bioethics, then the core curriculum, the core bioethics come in, and then of course the vertical part, which is the subject specific ethics, and they were put together. Here again, the assessment, we saw clearly that it was the pre-test, post-test certainly showed that there was good absorption, good learning, and good knowledge transfer taking place. Here are some of the units, the teaching taking place and so forth, and particularly in the pilot centers that we ran, one at KMC at Manipal and the other at Father Muller Center. Both these were pilot centers where for 4 years the programs were tested out. And here's again one of the students who went out sends a letter back from the United States, a young chap who says he's now working in New York, as someone who's going to work in a less affluent area of New York as a pediatrician. I'm now glad that I was able to actively get to participate in the ethics program at med school and was able to help spread awareness among the less access. So we have many of those who got this program. Actually, now in many parts of the world, in the WHO, young students who are now become who appreciate what the program that they took part in. Okay, now we talked about the 3T program. That's the part of the faculty development, which is the how to teach. It's a STAR program because it's a course based on outcomes. I showed you the outcomes, and it was also a course based on evidence. And this is important here. If it's a course based on outcomes, the rationale for outcomes was based, we must have a rationale for outcome based. And this is not as early as 2001. You could see just once learning is targeted on outcomes, many of the problems we face in education and training can be solved. Then we also see Ronald Hardin's talking in 2007, clearly saying here, clear statements as to what students are expected to learn are not on the agenda. It was almost as if we expected students to join us in some sort of magical mystery tour with an assessment at the end. So this is important that we look at. So the 3 decades have elapsed since all this has, or 2 or 3 decades have elapsed, but since we were alerted to this need for outcome, but we are now trying to move into that. And so the explicit outcomes to be achieved, demonstrating awareness of the core curriculum, reflecting the 15 principles that the world accepted or adopted, demonstrating the use of the vertically integrated curriculum, the innovative methodology, the formative and summative assessment, and the bioethical deliberation to ethical clinical decision making. This was something that was found very wanting in the study, where ethical clinical decision making was poorly. The outcomes were very poor for those who already had training. And of course, at the end of this training is always a complete simulated micro teaching session on knowledge and technology transfer of ethics is mandatory. So that's part of this whole program. Why and how is the course based on evidence? You can see again, Ron Lardon in 2007 spoke about opinion-based teaching, and now we talk of evidence-based teaching. And this is an important aspect to this model. The faculty development program has been looking at this. Part of the BEMI program, which is the answer to medical education, could be the best evidence medical education, where for health, medical and health professional education. We are part of this. My co-presenter is the chair for the BEMI, one of the BEMI chairs. So this was an important aspect of our faculty development program, because the BEMI goals, the best evidence medical education goals, are to provide and make available the latest findings from scientifically grounded teaching and educational research, to enable teachers and administrators to make informed decisions in the area of education. So the changes that we looked for were based on what was identified that went wrong in the 2 studies that were taken, which were done in the continent of North America, where mandate more than 30 years teaching of ethics was an accreditation requirement. And there, the changes that we looked for was based on what was wrong there. Again, I'll just remind you of the 2 studies. Universities teaching ethics for over 30 years. The results were unsatisfactory. And of course, that was what went wrong. And so this whole program was based on what was wrong. So evidence as the basis for the, so this becomes the important part, that was the evidence that was the basis for the 3T course, the integration of bioethics in all circular areas, namely, and curricular areas, namely bedside and clinical arena, something that we was found wanting in the earlier teaching in North America. Implementation of a vertically integrated curriculum that went seamlessly from the beginning to the end of the training program. Innovative methodology of how to teach this using osmosis methodology in learning. And of course, and the changes were also based on evaluation, a continuous follow-up program, looking at final waiver, the assessment formats, feedback, satisfaction, and I talked about the reported pilot course that went and which was reviewed for 5 years. The 2 pilot programs were running. And just to show you, the updated changes were based on results of over 4,000 faculty have been trained, and the results and the changes were based on what was evaluated from these 4,000 trained teachers. Now, what about innovative methodology? We talked about that, which becomes the foundation in delivering knowledge transfer in the medical humanity, in bioethics, where there is less scientific certainty. What we see is the use of role play, acting, debates, model games, cinema, tableau, participatory theater, etc., have been found used. So let me share what we're doing at one of the programs of our international program of the Department of Education at the University of Lisbon. Starting point, bioethics cannot be taught just in books. So we use commercial videos since 2005. And so there's a whole area of how to use commercial movies, identification of an ethical dilemma, decision on the main message to be conveyed, selection of scenes from commercial films, decisions on the structure of the lecture, introduction, development, and conclusions, including discussion and students voting, picking out, getting them, and so that was how we used it. And then designing the PowerPoint presentation. How to use commercial movies. Part 2 was presentation of video selected scenes, slides with main messages, group discussion on the underlying ethical issues that are portrayed in this in the video, and then taking a voting process, interaction, feedback, voting, interaction, feedback, and the facilitators' life stories related to the dilemmas, being able to offer life stories related to dilemmas that we face, and students reflective. We look at reflective practice, teaching and encouraging students' individual reflections. And here are some of the video scenes from 4 movies that I used in just after getting producers' permission. The different ones: Awakenings, Lorenzo's Oil, Patch Adams. These are some of the 12 video scenes from the movies that were used, as you can see. So continuing with this, teachers asked to vote on dilemmas too. We asked them as a starting point for discussing: should the patient be called by should the patient be called by a patient or by their name or by a number or bed number? Should teachers use crude medical terminology in bedside teaching? How do what terminology do you use when you're doing bedside teaching with the patient listening? So seamlessly aligning the sessions, raising questions, causing conflicts, giving examples, telling life stories, So what we see here is that bioethics curriculum must be dynamic based on outcomes and evidence. It requires innovative methods capable to triggering ethical conflicts. So it's important. This is the key messages that I end with, that ethics curriculum must be dynamic based on outcomes and evidence. And it requires innovative methods that are capable to trigger an ethical conflict. And so the learning takes place. Thank you very much for your.
Thank you, sir, for a very informative and a very interesting talk. It would have been really nice to have you here, but I know because of the pandemic, you couldn't make it. So we extend a heartfelt gratitude. Thank you so much, sir. Thank you so much.
Thank you. Thank you all.
So this is the certificate which will be sent to you, Dr. Russell D'Souza.
Yes, thank you. I appreciate and thank you for for awarding me with that certificate.
Thank you, sir. Thank you, one and all. Yeah, sir, we have few questions, sir, please.
Yeah.
So can you hear me?
Yeah, I can hear you.
So can you see the center of the stage? Is it visible?
Oh, good. We can see everyone now.
Can
Now
please
I
come
can
in
see.
front.
Yes, yes, I could see.
So would you like to say something to them, please?
Yes, yes. Look, welcome. This is the new batch of your student wing. When I came down many years ago, we not that long ago, but we did have a student wing, and I think Sri Guru Ram Das University has had. We had ethos also held by the student conference that was held. One of the most successful ethos was held there. In fact, there is ethos virtually taking place next month, and all of you should be involved in it. It is now international, and we're delighted because the Department of Education has focused and has a whole area for students. We've actually introduced or have what's called the the Association of International Medical Student Association. And right now we have a program. There are more than 40 or 50 countries with a vice president for each continent: North America, South America, Europe, Middle East, Africa, and Asia. And so this is very interesting, very innovative. The students are running and really doing a great job. So I'll be delighted to have you all join in this program. I think every 4 months or so, they are having a seminar for students, medical students from all over will be joining, and we'll keep you informed in that. We have an international student committee that's building and working with medical students. Of course, IFMSA is involved. They're part of the International Federation of Medical Students Association. So welcome, and we'll look forward to this, to all of you. I can see that we have two heads. Kushman Kerr is one of the heads, and then you have the Ganiv Singh as the other head. Is that right, Shaiba? These are two heads of the student wing. Is that right? And you have about 13 other members. I'm delighted to give you the writs of appointment now as the student to the student wing of the unit at the Sri Guru Ram Das University.
So can
And
I
we'll be, yes, please do that.
Sir, please focus the camera.
Kushman Kerr, let's give it to his. Kushman Kerr, congratulations. All the best to you. Congratulations to you, Ganesh Singh, and wish you the best in your role as the head of this student unit. Then we'll have Satraj Singh. Where's Satraj Singh? Congratulations, Satraj Singh, and best wishes. Manveer Kaur, congratulations, Manveer, and all the best. Gunjan Malhotra, congratulations, Gunjan Malhotra, and all the best in your role. Nabrun Singh Sindhu, congratulations, Nabrun Singh, and all the best to you. Manish Worker, congratulations, Manish. And then we have Manan Sharma. Congratulations, Manan, and all the best to you. Harish Deep Singh, congratulations, Harish Deep Singh. Sanmeet Singh, congratulations, Sanmeet, and best wishes. Then Haranjot Kalra, congratulations, Haranjot. Then we have Rishabh Bansal. Congratulations, Rishabh. Anhat Kaur, congratulations, Anhat, and best wishes for you. Jipnur Kaur, congratulations, Jipnur. And Jasmine Kaur, congratulations, Jasmine, and all the very best in your program.
So they want a picture with you, standing you behind. Yes, sir. Please come.
I'm delighted. I would have liked to be there, but hopefully we'll be there next year.
Thank you so much, sir.
No, not at all. Congratulations.
Sir, one
Lovely.
question
Thank
is the
you,
chat box.
Saiba, for
Yes.
organizing such a nice function.
Yes, sir.
Okay.
So there is a question. Did the cultural and religious setup influence the ethical values in the particular group?
Yeah. Philip Raj, I saw that from Philip, but look, the important thing is for you to, one of the important issues that come up in the Universal Declaration on Bioethics and Human Rights, the 15 principles were accepted after deliberation from 195 countries, governments, and advisors. One of the good things is that the Universal Declaration, the core curriculum, brings bioethics from a way that does not impact. That is why it's called the universal, because it took a couple of years to develop this. Can you imagine 195 countries governments agreeing on such important areas? We would find it hard to do it within one country for all to address it, and that's one of the strengths of the Universal Declaration, that it was meant for many cultures, many people with many different histories, and also different religions.
Thank you very much, sir. So it's beyond borders.
Yes.
Thank you, sir.
Thank you, sir. Thank you, Dr. Priyanka, Dr. Sneha, dear students. With this, we end the session. Thank you, everybody.
Thank you very much, and all the best to everyone.